Then stage of diagnosis. Since the introduction of PSA screening, 81% of newly diagnosed men have localized disease, whereas the incidence of the metastatic disease has decreased by 75%. The family history remains a strong component, and there is a relative risk increases according to the number of the affected family members, their degree of relatedness, and the age at which they were affected. Prostate cancer has a significant polygenic inheritance. It is one of the non-modifiable risk factors for the disease. And there are several prostate cancer susceptibility loci have been identified on chromosome 3, 5, 6, 7, 9, 11, 15, 16, and 17. The HOXB13 and BRCA are the two genes that substantially increase the individual risk. BRCA-associated cancers, especially the BRCA2, are more common to present with the higher grade locally advanced metastatic disease and have poorer cancer-specific and metastasis-free survival after the prostatectomy. Inflammation, chronic inflammations plays a very important role in prostate cancer. Inflammation resulting from the infections, diet intake, and other causes likely contribute to the development of the progression of early stage disease. The SELECT trial studies found that inflammation on negative biopsy was associated with the later development of the prostate cancers. Inflammation and infections play a role, though no infective organism has been identified. The inflammatory infiltrates and histological lesions called proliferative inflammatory atrophy are frequent in clinical prostate specimens. This inflammatory atrophy, proliferative inflammatory atrophy, often found adjacent to the high-grade prostate intraepithelial neoplasia or early cancers, and there is an identifiable genetic pathway between PIA, high-grade PIN, and the cancers. At present, no infectious agent has been proven to cause the prostate cancer. This picture shows the normal anatomy of the prostate and the pathological prostate inflammation, whereby these pathological agents result in the epithelial barrier damage, pro-inflammatory cytokines, and the direct genotoxicity on the epithelium. Androgens play an important role. The primary androgen of the prostate is the dihydrotestosterone, and exposure to dihydrotestosterone is a prerequisite and AR plays a key role for development of the prostate cancer. Polymorphism in both synthetic and metabolic genes, including AR, the type of 5-alpha reductase isoenzymes, and genes involved in the testosterone biosynthesis have been reported to affect the risk. Exposure of the prostate to androgens before or at puberty seems to be the prerequisite for later development of the prostate cancer, but beyond a certain level of exposure in adulthood, the risk is not linear as measured by the serum androgen levels. Estrogens have both direct and indirect effect on prostate growth and development and likely play a role in the prostate cancer initiation and progression. Age-related prostatic disease parallels increase in the serum estrogen, and there is a low incidence of the prostate cancer in cultures with diet rich in the polyestrogens. The obesity has also been shown to, the metabolic syndromes, obesity has been shown to be associated with higher rates of the biochemical failure after surgery or external beam radiotherapy, and 15 to 20% increase per 5 kg per square meter increase in BMI in prostate cancer specific mortality. Gene fusions from the chromosomal translocations are most common genetic alterations in the cancers. The other risk factors, which are the modifiable risk factors like sexual activity, sexual transmitted diseases, the alcohol consumption, though there are no conclusive evidences of its involvement. Vasectomy used to be said that it has an increased incidence of the prostate cancer, but there is no evidence about it. There is no definite association of dietary fat intake with the prostate cancer incidence. The various drugs and statins have been shown to have a weak role in the prostate cancer etiology. Smoking is one of the causes which has been 9 to 30% increase in prostate cancer and increased risk of the BRCA metastasis. The smokers have a higher incidence of the metastasis and specific mortality, prostate-specific mortality. Now the prevention, the rationale for the prevention of the malignancy, the agents which should be used, that it should reverse, suppress, or prevent the carcinogenic process by thereby preventing the development of clinically evident cancers. The primary chemoprevention would be target at-risk healthy individuals. Secondary prevention would be to target the individuals with pre-malignant lesions. And the tertiary prevention would be target the affected individuals to prevent the development of these second primary cancers. There are various agents which have been studied for the prevention, like drugs, 5-alpha reductase inhibitors, tormifin, citrate, metformin, NSAIDs, and statins, and the nutrients like selenium, vitamin E, soya, lycopenes, and the green tea catechins. There are various trials which have been conducted for the chemoprevention. Some of them are SELECT, REDUCE, and PCPT trials. The PCPT trial is the first primary chemoprevention trial, which was conducted 2003 and 2003, and it randomized 18,882 men over 55 years age with normal DRE and serum PSA. The finasteride 5 milligram versus placebo was seen in this trial. The rationale for use of finasteride in this trial was the absence of prostate cancer in men with congenital deficiency of 5-alpha reductase. The primary endpoint was prevalence of the prostate cancer at 7 years. The main findings of the study was the 25% reduction in the period prevalence of the prostate cancer taking finasteride. That's 18.4% versus 24.4% in the placebos. The relevant findings of this trial were the marked effect on the prevalence of the biopsy Gleason score 2 to 4 to 6 tumors, no effect in the prevalence of biopsy Gleason score 7 tumors, and increase in the incidence of the prevalence of the biopsy Gleason score 8 to 10 tumors. The secondary analysis of the PCPT trial showed the overall improved sensitivity of the DRE, higher accuracy of the PSA for diagnosing prostate cancer in finasteride arm, and finasteride treated glands were 28% smaller. There was no overall survival difference in long term at 15 years. The REDUCE trial, which studied the chemoprevention of prostate cancer in men at risk, the rituximab used for prostate cancer event trial. It was again a large-scale randomized placebo-controlled trial, men 50 to 75 years of age, prior negative biopsy in them, and the baseline serum PSA of 2.5 to 10 nanograms per ml, prostate less than 80 cc. Primary endpoint was the prevalence of prostate cancer on 10 core biopsies at 2 and 4 years after randomization. Rituximab reduced the risk of prostate cancer by 23% over 4 years. There was significant increase in the detection of the Gleason 8 to 10 prostate cancers in 3 to 4 years. The FDA reassessment showed a significant increase in Gleason 8 to 10 cancers across the both trials. This is the summary of the PCPT and the REDUCE trials. The FDA concluded that 5 ARIs did not have a favorable risk-benefit profile for the chemoprevention of the prostate cancer. The Tormifin citrate is a modulator of the ER and is FDA approved for the prostate cancer, breast cancer. A randomized trial in 1,467 men with high-grade PIN failed to show a reduction in prostate cancer incidence at 3 years among those receiving Tormifin citrate 20 mg daily versus placebo, even among the select high-risk groups. The select trial, the effect of the selenium and vitamin E on the risk of prostate cancers and other cancers. It revealed that neither selenium nor vitamin E should be used in the hope of preventing prostate cancer or other cancers. The 17% increased prostate cancer risk associated with vitamin E in the select demonstrates the potential for innoxious yet biologically active substance. The role of statins and metformin. A recent meta-analysis of 27 observational studies concluded that statin use reduces the overall risk of prostate cancer by 7% and the risk of higher grade or advanced cancers by 20%. But they concluded neither metformin or statins have been tested to controlled intervention trials for their potential ability to reduce the prostate cancer risk. In conclusion, the prostate cancer is an attractive target for the primary prevention. PCPT trial demonstrated that the finasteride, the period prevalence of prostate cancer by 25% with no effect on the overall mortality. The SELECT demonstrated that neither vitamin E nor selenium prevent prostate cancer and increase risk of prostate cancer with the use of vitamin E. Thank you for the patient hearing.
So, Dr. Vani, we mean to say that dutasteride or finasteride practically have no role as far as the cancer prevention.
This is exactly what the studies have shown, that it does not have actually a preventive role in the prostate cancers.
Thank you, Dr. Vani.
Thank you.
May I request the chairpersons for the session, Dr. Vijay Bora, Dr. Santosh Kumar, Dr. Nitin Agarwal, Dr. Vishal Vig, Dr. Abhishek, to kindly come and conduct the next session. There's nobody, so then I will. Dr. Santosh, आप फिर यहीं से कर लो फिर. सर आप कर लो ना. आपका प्रोग्राम आप आगे आ जाओ. आप डॉक्टर नितिन तो है ही है ना, तो आगे फिर वहीं नहीं सर ऊपर बैठ के सर फिर तरीके सर ऊपर ही चल आ जा
नहीं आप करिए सर. नहीं करिए सर आप सीनियर मोस्ट
बायोप्सी. अच्छा मधुबनी निकालो जरा. हाँ निकालो
निकालना
क्या है.
सर ट्रांसपेरेंनियल और वो बायोप्सी का ट्रांसपेरेंट पहले सबनिस का है सर. ट्रांसरेक्टल बायोप्सी ट्रांसरेक्टल डॉक्टर सबनिस.
So, good morning everybody. Now I will request Professor Sabnis to give his talk on transrectal prostatic biopsy. Professor Sabnis, please.
Well, good morning everyone. Thank you North Zone USI for giving me this opportunity. And this session is particularly devoted to the prostate biopsy. And I'm going to talk on the transrectal biopsy. First and foremost, why at all there is a discussion on this session and there are discussion on this transrectal biopsy. You see here in this particular session, there are multiple talks are there, transrectal, transperineal, gluteal, PSMA guided, and this like that. So why this discussion is now? Till now, there was only transrectal route was the only route for taking biopsy. However, now, over a period of years, and the talk is going on that whether there is any role for biopsy itself. So that role also is getting challenged. New methods of biopsy are coming up. MRI is very sensitive and specific to detect cancer, but it's extremely difficult to take MRI guided biopsy of the prostate. And transrectal, it is not sensitive, not specific, but it's very easy to take biopsy. And that is where the dilemma comes in. And therefore, that whole session on this biopsy, and there are discussion on which route to be taken up. Trust guided, I'm going to talk on the trust guided transrectal biopsy. And when we talk about this, I will just give you a brief idea as to how many cores and why, then some technical aspects, and then what are the problems and why it is being challenged. And there are some other routes which have been, which have come forward. What are the challenges when we take prostate biopsy? What we want is that maximum possible yield, and we should not miss any cancer. That's the first and foremost when we take biopsy of anything. Minimum possible cores, that is what is the requirement. See, if you see each core, then it has the maximum amount is 0.08 cc. So if you have 6 cores, you are sampling only 0.48 cc. If you take 12 core, which is now standard, you are sampling only 1 cc. So out of 30, 40 cc's of prostate, which is usual gland, you are taking only 1 cc, and you want that to represent the whole prostate. That is where the challenge comes, and therefore there is a systematic approach to this random biopsy. If you see 12 core biopsy, which is now a standardized 6 core biopsies all given up, 12 core biopsies detection rate, if the prostate size is 40 grams, then it is about 30 to 40% chance that you will detect. And as size increases, the possibility goes down. And therefore, the number of cores and how you take is very, very important. 610 biopsies all gone. Now 12 core is the standard one, which is now considered. If you are taking more than 12 cores, either for negative biopsy or some identified areas which are additional biopsies, then that's a saturation biopsy in which there are more than 12 cores which are taken up. Now, coming to the technical aspect, what is the simplified preparation? There's a lot of talk about how to prepare patient for biopsy, and there are many trials which have been done, giving simple enema, starting antibiotics beforehand, giving only the Dulcolax on the previous night, and not preparing anything at all. And what they have found that even with the simplified protocol and the complex protocol of giving enema and cleansing enema, giving bowel wash and this, that, there is no significant in any of the complications which are related to biopsy. And therefore, now the advice is that there is no actual additional extensive preparation which is required. If patient has good amount of stool on DRE, the rectum is empty, that is more than sufficient for you to take biopsy. The next thing is about the anesthesia. Intrarectal lidocaine, what we inject, is very easy, reproducible. Theoretically, it will cross the rectal wall and will go to the periprostatic nerves. But in the realistic world, it doesn't happen. And therefore, when you are taking more course, you need to have some sort of anesthesia. Otherwise, patient will have discomfort and pain. So where exactly the anesthesia is given? If you see the anatomy, this is the probe, this is the bladder, this is the prostate. The nerves actually will go from here, from the base to the down. And therefore, this is the area which is to be targeted to inject the local anesthesia so as to have the maximum effect. Now, how actually it is seen on the transrectal biopsy in the longitudinal section, if you see, and if you go on the extreme side, either right and the left, this is seminal vesicle, this is a prostate, and this is the area which you see, this is called as Mount Everest sign. And this is how it will be seen in the, when you do truss. And this is the site where actually the nerves are going in. So this is the area which you have to target, and if you inject the local anesthesia here, it will give sufficient anesthesia so that you can comfortably do the biopsy. So this is how it is done. You inject with the truss guided probe, see the junction, inject this, let there be elevation, This is how it looks like. This is where it is injected. This will get elevated, and that is more than sufficient. You do it on the right side, you do it on the left side. Now, how you do it? There are different probes. There are end firing probe, side firing probe, simultaneous biplanar probe, triplanar probe. So whatever you are whatever you are used to, you can go it. If you ask me, the ideal thing is the side firing probe. But if you don't have it, if you have an end firing probe, you can do with that also. This is how it is done. If you have a biplanar machine, you know where exactly you are injecting, where exactly you are taking biopsy. That gives additional guide. But with experience, it is not required. Triplanar, in some cases, you can take with side firing and additional with the end firing also. So that is a benefit. Perineal, I'm not going to talk. This is the common, these are the biopsy guns. This is the reusable biopsy guns. You can use it multiple times and needle can be changed. And this is a single monopty gun. What is important is that when you are taking this biopsy, you need a spring guided biopsy machine so that in a fraction of a second it goes and comes back. All the transrectal biopsies are the laterally directed peripheral zone biopsies. This is how you take it, apex, base, and mid zone. And in reality, this is how you do it. Guide the target area where you want to take the biopsy. See where exactly you want to locate it. You have an exact plan from where you take it. If you want to take the biopsy from the base of the prostate here, bring this line and fire, and it will take the biopsy from that particular thing. You can adjust there is always adjustment 15 mm, 21 mm core. This is a 21 mm core which you can take. And every time when you take biopsy, you get a nice good core which can be sent separately. All the cores should be sent separately. The only benefit of this is that if the biopsy is negative and if you have area in some areas where is a high grade pin or ASAP, then you know that this is the area where you want to target it next time when you are doing biopsy. Otherwise, if the biopsy is positive from where it has come, it has not much relevance at all. End firing probe has a benefit is that especially in the anterior horn cell biopsy, you can actually go inside and then fire so that it takes the biopsy from the anterior area very easily. So that's where the benefit comes in, especially when you have previous biopsy negative, then that is where the transrectal end firing probe is useful. Lastly, coming to the problems of this transrectal biopsy, why it is being challenged is because infection. Sometimes there are serious infections requiring ICU admission, and there are certain areas which are missed in the transrectal biopsy, and those can be targeted by some other methods in a different way. Now, this particular problem is highlighted a lot. We have been doing transrectal biopsies for several years now, and hundreds and thousands of biopsies. What infection rate which is reported in the Western literature and what is our incidence is much, much less. Hardly any patient gets ICU admission and serious sepsis like that. Although the literature reported incidence is 5 to 7% with transrectal biopsy, and serious infection requiring ICU admission is about 1 to 2%. But in our practice, it is much less. Only challenge which comes and only problem which comes in transrectal biopsy is that these are all peripheral guided lateral biopsies, and therefore the anterior horn cells, anterior area biopsies, sometimes the transitional biopsies, they are the areas which remain blind, and that's why not to miss these areas, the other modalities have come in. But otherwise, transrectal biopsies have done a remarkable job, and it is more than sufficient in the normal way to take biopsy from the prostate. Thank you very much.
Thank you, Dr. Sabnis, for nice talk. Any question from audience?
Yes, Dr. P.P. Singh.
Sir, you did mention about the anterior fibromuscular stroma zone.
Yeah.
So my question was, because all of us are practically doing transrectal at present.
Correct.
And trying to do transition to the perineal if possible.
Correct.
Now, what is the best way out to hit the anterior fibromuscular stroma and to prevent any urethral injury in those situations?
Urethral injury is very unlikely because you know that urethra is there, and your 12 core biopsies are 3 from the extreme lateral, 3 from paramedian, so there is not a problem. Now, not to miss the anterior biopsies. Sometimes there are, because peripheral zone actually extends on the anterior, and that is called as anterior horn biopsy. Not to miss that, what you have to do is that normally, typically, we just thrust the needle and then fire, so that you get a maximum peripheral zone and then little bit of a transitional zone. Here, what you have to do is that you inject the thrust the needle significant amount up to the mid part of the transitional zone and then fire, so that you get the TZ and then what is there anteriorly. So you have to inject, you have to thrust the needle significantly and then fire, so that this will not be missed.
And the view which you try to see is transverse at that point of
No,
time? or
always
the-
longitudinal.
Always longitudinal.
Always longitudinal. Transrectal biopsy, the biopsies are taken always in the longitudinal section, because in the transverse section you will appear, this puncture line will appear as a dot. That is only to get the guide. But your line will be seen only in this longitudinal section. Yeah, Malik?
No, I just, Sabnis, if you look at the whole, with the side firing probes and the end firing probes, the way we describe in our saying that upper or base in the mid or the lower zone, it doesn't exactly correlate to that with side firing probes. We end up in having a core which goes quite parallelly in the peripheral zone all across into many zones. If suppose you really biopsy a 2 centimeter size prostate, the whole core of the whole zone of that from above base down to the apex will be in one biopsy. Do you agree on that or not? The picture what you have shown is classical for an end firing probes, but not classical
No,
for
what
an
you
end
said is
firing
right.
probes.
What you said is partly right. But if you take the probe and move in a particular way, if you go to extreme periphery and retract your probe at the apex, then the puncture line will take not the whole peripheral zone, but it will actually go little bit lateral
Exactly,
directed
I understand.
perpendicular.
See, the basic reason for we selecting a side firing probe is because it is parallel to the rectum, so
Correct.
that the pressure onto the rectal area is
Much
minimized.
less.
So the moment you have it parallel to the rectum, the side firing probe which goes in, which goes with a 20 or 25 degree
It is
angle.
almost 40-degree tilt, so that
Okay,
it will
so,
take a 40.
Yes, it will not be
It
coinciding.
will not be perpendicular.
Absolutely
No
perpendicular.
question.
That's
That
exactly.
is where there are blind areas, because
exactly
if this
the
is the
reason
area
what I'm
and it is
saying.
perpendicular, this area is going to remain blind.
In fact, if you look at a small prostate, I don't think we need to take that sort of a perpendicular or angled. You can just do a parallel
Correct.
course as if you do
Yeah.
it in a perineal course. You will get it in that fashion.
This is a
Most of the
45
time-
degree.
Most of the time,
Yes.
you tilt it in such a fashion that
Yes.
it comes 90 degree to the prostate or parallel
Yeah.
to the prostate, and the whole peripheral zone can
Correct.
be
Correct.
biopsied.
Correct.
I'll, Dr. Sabnis,
Okay.
I agree with you everything. I just want to add my personal experience.
Yes,
You can
yes.
say like that.
Yes.
One is that we do the cleaning of the perianal area, what I do, I also take the betadine swab, put inside the rectum and clean the anal canal from where our needle is going.
Right.
That is the one factor which I found
Okay.
significance of the infection rate has gone down significantly.
Correct.
The second point is intrarectal jelly. That I also inject in every case. Why? Because there is a punctate line
Correct.
in the rectum. When we pierce the mucosa, it is very painful.
Correct.
Especially when you are taking the apical
Apex.
cord.
Apex is the one which
So
can be
that's
painful.
why
Yeah.
intrarectal jelly may not go up to the prostate,
Correct.
but it will desensitize the mucous membrane of the rectum.
Correct. I agree.
But urosepsis is one of thing we are in PGI, we are doing around 400, 500 biopsy annually, prostatic biopsy. And we have seen at least 1 to 2% of cases land up in sepsis, frank sepsis.
Okay.
And UTI is also common because most of these patients is obstructed. So UTI and urosepsis is one of the side effect of transrectal biopsy. Or now we are routinely doing last 3 years we have done more than 200 PSMA PET guided transperineal biopsy.
Okay.
And we have seen rarely any urosepsis cases.
All right.
So later on Dr. Rajendra will
Yeah,
present our
okay.
data on that also.
All right.
Thank you, Dr.
Thank you, thank
Sabnis.
you.
Now second speaker is
I will welcome Dr. Dharmendra Agrawal for the topic on transperineal biopsies.
Good morning, everyone. My name is Dr. Dharmender Agarwal. I'm consultant uro-oncology and robotic surgery from Fortis Hospital, Mohali. Today, I'm talking about technique of transperineal prostate biopsy. So we all know that prostate biopsy is the method to diagnose prostate cancer, and transrectal biopsy has remained most utilized in last many decades for the diagnosis of prostate cancer. However, the transperineal approach has also been gaining popularity for last 2 decades since its introduction. So the question arises that why do we go transperineal? As we already discussed, there is a better sampling of anterior and apical regions in the transperineal prostate biopsies. We also have found better cancer detection rates. We are able to better access to target the specific lesions. We are able to avoid the posterior plane, so that gives a better plane while doing a radical prostatectomy, and it allows a better chance of nerve spare, and also lastly less sepsis and less infection rates. When the transperineal biopsy was initially introduced about 2 decades back, it was done with the MRI guidance, and a metal grid was used, and it was considered very painful, and it required general anesthesia or sedation. The patients were taken to the operation theater. They were unlikely to tolerate it under local anesthesia, and it wasn't done on the outpatient basis. However, since the last few years, many attempts have been made to perfect the technique, to decrease the number of cores, and to be able to do that transperineal biopsies under local anesthesia as outpatient. Use of cognitive MRI fusion to target the lesion is the new way to do the transperineal prostate biopsies. Now, I'm going to talk a bit more detail about the technique of how to do the transperineal biopsies and how it is being done and how it is being perfected. So the materials required for a transperineal prostate biopsy are slightly more than the ones required for transrectal. We need an extra spinal needle. We need a access system, which is called perineal access system, to allow a freehand prostate biopsies. And then we need an ultrasound probe which has a linear scanner over it, a transrectal probe with a linear scanner. So this is a quick video which shows that the access system has a round body below it, which is helpful in attaching it to the ultrasound probe. And then the 14 gauge needle goes over the access system, and we can slide the access system and the needle to fit it to target the specific areas. Now this is how the assembly looks like. This is a transrectal probe with a linear scanner, and we put the access system in a way that the needle is overlapping the scanner area so that we can see this needle during the ultrasound images. The patient is placed into the lithotomy position under a local anesthesia. The scrotum and penile part is covered with a sponge and tape so that it doesn't hang outside. And this is a graphic presentation of the same video of how this access system works. So we make 2 punctures on the side of the midline. We don't go into the midline to avoid the urethra. And then we enter into the periapical area and give local anesthesia, lignocaine, into the periapical as a periapical block. And then we move the transrectal probe up and down to target the different areas over the prostate. If we have to take the peripheral zone, posterior part, we are putting the probe down, and to target the anterior part, we put the probe up. We also move the probe left and right to target from the medial to lateral and vice versa. So this is a diagrammatic representation of the periapical block. We can see that we, as the Sabni sir discussed, that we do not give periprostatic block exactly between the prostate and seminal vesicle, but we only give the block in the periapical area because the needle enters from that part only, and that whole part is sensitized. So this is a real video of introducing spinal needle for a periapical prostatic block. As we can see, the prostate is being seen in the longitudinal section, and the spinal needle is entering, and while withdrawing the needle, we are giving the lignocaine, which raises the area, which raises the fibers there, confirming that the local is being injected. Now, after the local is given, we wait for at least 1 minute to allow it to work, and then TrueCut spring spring gun is used that is passed through the needle of the access system from one side, and the biopsies are taken in a predefined, pre-specified manner from medial to lateral or lateral to medial, in whatever way you prefer. And then peripheral zones are sampled separately, and transitional zone or anterior zone is sampled separately. Hands are lifted up and down and moved left or right with the probe to target the specific areas. And after firing the gun, we take the axial image to confirm the needle position, to confirm which core has been taken. And we usually take 10 to 12 cores as required. So this is a small video showing the targeting of the right transitional zone area. As we can see, the needle is entering quite anteriorly in the prostate and not exactly on the peripheral zones. And when we confirm it, we can see the needle targeting on the right transitional zone area. Again. And this term, yes, this is freehand biopsy, but with the with using that access system. And then this is another small video where we are targeting a left anterior lesion. Again, we are targeting, the needle is going quite anterior onto the prostate. The peripheral zones are quite in the back. And again, we confirm from the axial images that we have taken the proper area in this sample. So by this technique, there is 2 skin punctures, one for the left and one for the right side. The perineal access system goes into one puncture site. We give the local at that area, and then we sample whole of the left side from the left puncture and keep moving our hand from the medial to the lateral side to sample the peripheral zone from medial to lateral. And if we have to take the anterior samples, we can also move the needle into the access system into the anterior part. However, the puncture in the skin remains only 2. Now coming to the benefits of transperineal prostate biopsies, for the cancer detection rates, it has been found that for the biopsy naive cases, the perineal biopsies shows the detection rate of about 69% compared to 55% for the transrectals. For previously failed transrectal biopsies with a high suspicion of prostate cancer, people who have failed more than 2 previous negative TR biopsies has a 55% of CDR, that is cancer detection rate. And for people on active surveillance, it has been found that 34% patients had more significant cancer than it was found on transrectal biopsies. And there was an upgrading rate of 71.9% to clinically significant prostate cancer with template TP biopsies. Similarly, for the anterior lesions, 47% of the new positive biopsies were found in anterior lesions after a failed transrectal biopsy. Among 30% of the new biopsy positive cases, 83% of those were in the anterior zone, which were detected by the transperineal. And by all this data, it has been mentioned that the systematic transrectal biopsy misses about 20% of the clinically significant prostate cancers, which are mainly in the anterior and apical parts. We have already seen the complications rate, but for the transperineal, the complication rate for the sepsis and hospital readmission has, in the multiple studies, persistently remained less than 0.5%. Also, in the community, there has been an increasing inappropriate antibiotic usage, especially in our part of the world, in the developing countries. And most common organism for these infections is E. coli, almost in 92% of cases. We have found many times that there is an increasing evidence of resistant E. coli bacteria, which is not usually taken care by the pre-biopsy prophylactic antibiotics which we give to the patients. And the transperineal biopsy is said to avoid this rectal bacterial inoculation into the prostate. Coming to end, the summary of benefits in the transperineal technique is, it was initially, as I mentioned, was handicapped by the use of general anesthesia and hospital admission. But with this new perfecting the technique things, we are able to do it under local anesthesia. We are able to do it as a daycare procedure. Patient still goes to the operation theater for the lithotomy position, but the patient is discharged after 2 hours of the biopsy. It is more anatomical. It is the safest and shortest route to the prostate. The reduced perineal punctures to 2 in number, and it is a freehand technique. So the question is it time to shift from transrectal to transperineal? Thank you.
Thank you. Thank you, doctor. Any comments?
Hello. Do you give any local anesthesia to the perineal skin also?
Yes.
Yes.
So when we before introducing the ultrasound probe, we put the lignocaine jelly into the rectum, and after that we put the access system over the rectal probe. We put the rectal probe into the rectum, and then we give a fan-shaped lignocaine anesthesia from the anterior anal verge to almost 90 degree on the left and almost to the 90 degree onto the right. And after that we wait for 1 minute, then we go for the skin puncture, and after that we give the periapical block.
All right. So, but you're taking from the single puncture, you're taking multiple, right?
Yes.
So are they longitudinal or they are slightly angulated biopsies?
So they are almost longitudinal, but in the skin puncture remains same for one side, and we move the position of the probe in a way. So most of the times, if we are knowing that the MRI scan is showing the lesion only in the peripheral zone, we usually take them on a straight direction. But if the lesion is only on the anterior, we put the needle through the anterior most system of the access system. So as if we can see.
So in the prostate it goes in, the different punctures are there in the prostate.
In the prostate it goes into the different puncture.
Punctures,
in the skin it remains in only 2 punctures.
Okay,
Yes.
right.
Dr. Dharmender, even that transrectal biopsy and transperineal biopsy, it has shown sensitivity rate is 60%, around 60%. But we have started PSMA PET guided biopsy, which has got much more sensitivity and specificity.
Yes, sir.
And Dr. Rajendra Kumar, he is professor of nuclear medicine in PGI Chandigarh. He is going to present his PSMA PET guided transperineal biopsy. Thank you.
Yes,
Thank
sir.
you, Dharmender.
Thank you, sir.
No, I just wanted to ask one. Number one, which system is it? And the guidance system. And the second question that I want to ask is, what is the method of using fusion technology in this? If you have a lesion marked on MRI, can you fuse that with the ultrasonogram machine?
So we are not doing that yet, sir. The system is coming from a company named Perineologic. The Perineologic company produces this access system, it is called as a transperineal access system. That is the name of this, produced by Perineologic. And at the moment we are just seeing the MRI images and understanding where is the lesion, and then we are identifying that lesion on the ultrasound probe. So we are not superimposing the image with the help of any software at the moment,
So
but
it's
I am
a
sure with the coming
sampling.
future.
It is cognitive
Thank you.
sampling.
Thank
It
you,
is
Dr.
cognitive.
Dharmender. So now I invite Dr. Rajendra Kumar. He will speak on transgluteal route for prostatic biopsy.
Thank you, chairpersons, and thank you, USI, for inviting me for this talk. So my topic is transgluteal prostate biopsies. So my previous speakers very well described the route of prostatic biopsy, like transrectal biopsy, transperineal biopsy, and they had discussed the pros and cons of transrectal biopsies and transperineal biopsies. Obviously, there is major the cons is that there is chance of infection in transperineal biopsy and transrectal biopsies. So, can we avoid infection through transgluteal approach? Yeah, practically we can say there is no infection in transgluteal biopsies. So, I'm not going to discuss understanding the problem. You all know what is the problem. The problem in question is prostatic carcinoma. So, I'm not going to discuss. And you all know the patients with with prostate cancer present with LUTS. I'm not going to discuss. This is for the purpose of non-urologic people. I'm not going to discuss also that. And what we are doing in diagnostic tool for prostate, we have MPMRI, we have PET-CT, and we have ultrasonography, and followed by biopsies. So routes and techniques you all know. There is transrectal biopsies, transperineal biopsies. They are well established techniques for doing biopsy from the prostate. And we can use TRUS and we can use MRI to target the lesions. So according to ESMO guidelines and UAE guidelines, they recommend upfront MPMRI in a clinically suspected prostate cancer before doing biopsies. So upfront MRI should be done in case of clinically suspected prostate cancer before doing biopsies. And they recommend that if we are doing transrectal biopsy or transperineal biopsy, they recommend that means antibiotics should be used in these patients before doing biopsies. And the yield of rectal biopsy is around 30 to 40%. And there is high false negative rate in rectal biopsies. And the CDR at the second biopsy is around 10 to 17%, and third biopsy is 5 to 15%. And for saturation biopsy, we can take multiple samples, 20 to 50 samples, and CDR will be increased to 18 to 34%. But if we increase the number of the core, the patient's pain will be increased, complication rate will be increased. And anterior-based lesions or apex-based lesions, my previous speaker has discussed the anterior-based lesions, they are more easily targetable with the transperineal biopsy than transrectal biopsies. I'm not going to discuss that. And now coming to the complications rate, there is obviously high complication rate. The routine complication like hematuria, rectal bleed, they may happen with each and every biopsies. But urinary infection, bacteremia, and hospitalization are the major questions that should be tackled while doing a biopsy from the prostate. So now coming to the gallium PSMA now is well documented and well established and acclaimed technique for staging, follow-up, and response evaluation of prostate cancer. Higher the PSMA expression, higher is the tumor grade, and it's related with more PSA levels. And patient with the indeterminate lesions on MRI may harbor a significant disease and may be missed on targeting under MR guidance also. So what is the need of gallium PSMA PET-CT guidance? The target lesion is more obvious to the interventionist on PSMA PET-CT as compared to transrectal biopsy with under ultrasound or MR fused TRUS-guided biopsies. At the same time, the whole body disease staging can be done in PSMA PET-CT. Additionally, PET-CT can help to detect the pathological lesions before the appearance of anatomical changes on prostate. And PET-guided biopsy is likely to be the procedure of choice in these lesions and slowly gaining pace in the clinical oncology. So how the story starts? We have published our data in doing biopsy from the abdominal pelvic lesions through the posterior approach, and we have published our data in European Journal of Nuclear Medicine, and we had found a sensitivity of 96%, 100% specificity, and positive predictive value of 100%. So from their story starts. We had done multiple biopsy using various gallium tracers also. So there were many patients who were PSMA PET positive and TRUS-guided biopsy was negative. And I used to discuss with my urologist colleagues that, sir, this patient is PSMA PET positive, but TRUS-guided biopsy is negative. So they keep on pushing me, why you are not starting biopsy from the prostate using PSMA? So, sir, I asked them, sir, how to approach these patients? I cannot approach through transrectal approach because it's not possible for me to do biopsy under PET-CT guidance to transrectal approach because I'm not having a specialist in ultrasonography. So they suggested me, so you had done biopsy from the pelvis from the retroperitoneum. So why are not going through the transgluteal approach? So you should go and do biopsy from the transgluteal approach. So I started this project and I registered this in clinical trial. So doing biopsy from the PSMA avid side of the prostate through the robotic arm through the transgluteal approach. So we registered this clinical trial. So our target patients were rising PSA levels with persistent elevated PSA levels, patient having pyrite 3 or equivocal lesions, but there should be a focal lesion in the PSMA PET CT. That could be anterior, that could be central, and in patients who had no rectal access, and in patients with post-APR, obviously there is no rectal access, we have to approach through the transperineal approach or transgluteal approach. So our target was these patients. And in patients who have no metallic implant or, and they are MR incompatible, these are the ideal patients who are doing biopsy through the transgluteal approach or transperineal approach, because in these patients MR cannot be done, upfront MR cannot be done, and these patients can be targeted under PSMA PET guidance. So at this, now we started this process of doing biopsy from the prostate through the transgluteal approach. And how we prepare the patients, apart from routine investigations, we need the urine routine examination or culture at 48 hours, because that is the usual trend in urology to do biopsies. And bladder should be empty, because if bladder is empty, the target will be better visualized on a PSMA PET CT. And the radiation exposure to the interventionist will be less, because if the bladder is full, there will be more radiation exposure to the interventionist, because there will be more radiation in the bladder. We have to empty the bladder before doing biopsy. And need for urinary catheterization is, in few patients, urinary catheterization is needed when the bladder is obstructed and full bladder is there. And bowel emptying, no distended. If what we need is bladder, rectum should not be distended, because it should not come in your way of doing biopsy. So no routine bowel preparation is needed for PSMA PET CT guide biopsy. And patient should be prone on the PET CT table. Sometime leg support is needed, and a surgical gown and loose pajama can be given to the patients. And careful review the reference regional PET CT study of the patient, and identify the most suitable lesion, whether this is anterior, posterior, lateral, on the apex, on the base of the prostate. And depending on that, we have to take the needle size. 18 gauge, 20 centimeter is the ideal needle length what we are using, because we are going for a long length, so we have to use 20 centimeter length. And depending on the laterality, whether the lesion is lateral side, on the right lateral or left lateral, we have to choose that. And this is a 68-year-old male patient with history of lower urinary tract symptoms for 3 months, had hematuria for 1 month, urine cytology was suggestive of urothelial carcinoma. Prior transrectal biopsy was done, that was inconclusive, and serum PSA was 8.8. So this is the PSMA PET CT in these patients, and we noticed a focal PSMA uptake in the prostate. This is the on the right side. So how we approach these patients? This is the PSMA avid site in the prostate, and this was our approach from the transgluteal to transischial fossa to parietal position to the prostate. So transgluteal, transischial fossa, right or left pararectal approach. This is our approach. We are not puncturing the rectum in our biopsies. So after this, we had recruited 76%, and our data was published in the highest impact radiology journal, that is impact factor of 29. And we recruited 78 patients in our trial, and of these 78 patients, 56 were PSMA PET positive, and all were taken for biopsies. And of these, 12 were prior negative trust guide biopsies, and 34 were biopsy naive patients, and all were undertaken for biopsy through transgluteal approach. And what we found that of these 56%, 54 patients had positive biopsies. All were diagnosed to have prostate cancers. And of 54%, 24 patients had clinical significant prostate cancers. And now coming to the complications, obviously minor complications were there, like hematuria, urinary obstruction, hematospermia were also noted in few patients. And obviously we are approaching through the transgluteal muscles. So patient had transgluteal pain in 2 or 3 patients, but they were normal after 48 hours. Now comparing the complications of transgluteal biopsy versus transrectal biopsies, there are many complications. Urinary tract infection is the more common in transrectal biopsy. Bacteremia is there, hospitalization is there. But in our cohorts, there is no bacteremia, no septicemia, no hospitalization was noted. Obviously, there was some hematuria was there, hematospermia was there, some 2 patients present with gluteal pain and lower muscle soreness, but that was relieved in 48 hours. And we have started another clinical trial of comparing the robotic arm-assisted pacemaker guided biopsy versus MR-directed truss guided biopsies. And this was registered in clinical trial. And what we are doing upfront MPMRI, and we are dividing the patient into two arms. One is pacemaker arm, and second is MR-directed truss guided arm. And what we noted that in the pacemaker arm, in pirates 4 and 5 lesions, 95% in pirates 5 and 87% in pirates 4 have detected to have prostate cancer, as compared to MR directed. There were 81 patients had prostate cancer, and 14 and 24%, 14%, 15% had prostate cancer in pirates 4 lesions. And in pirates 2 and 3 lesions, no biopsy was done under MPMR directed truss guide biopsy. And in this group, we detected prostate cancer in 19 patients out of 24. And now coming to the complications, obviously there is, we found no infection in our this series. And but in MPMR directed truss guide biopsy, 5 patients had infections, and no hospitalization was needed in PSMA PET guided biopsies, and 2 patients needed hospitalization because of septicemia and bacteremia, and bleeding is also per rectal is no chance of bleeding per rectal in case of PSMA PET guidance, and there were 35% had bleeding per rectal in MPMR directed truss guided biopsy groups. And obviously we had gluteal pain in 5 patients, but there is no gluteal pain, and there is 15 patients had a fever in MPMR directed biopsy groups, and we had no fever. And average VAS score was 3 in our group as compared to MPMR directed biopsy group, that was 6. Now coming to US guidance biopsy and PSMA PET guidance biopsy. US guidance biopsy is structural biopsy, and PSMA PET guided biopsy is functional biopsy. And lesion is never obvious on US guidance biopsy, and on PSMA PET guided biopsy, lesion is obvious, very obvious, and we can visualize the lesion throughout the biopsy. And antibiotic cover is not needed in PSMA PET guided biopsy. It almost always needed in PSMA ultrasound guided biopsies. And number of the puncture is higher, and we are doing only 1 puncture, and complication rate is higher and relatively less complicated, and infection is in practically no infection in PSMA PET guided biopsy, and there is a reported infection in US guided biopsy. And yield is 39 to 50%, and our yield is more than 90%, 96%. This is 74-year-old male with LUTS with PSA level of 5.2. A previous truss guided biopsy was done in this patient, that was negative, and he also had metallic implant in the right femur, so refuting MPMRI. So he underwent PSMA PET CT, and on PSMA PET CT we found a lesion on the anterior aspect with SUMX of 12.4 with MI-PSMA score of 2. So we did PSMA PET guided biopsy from this entry placed lesion through the transgluteal approach, and what we found that it's adenocarcinoma prostate with a Gleason score of 3+4. This is another patient, 67-year-old male patient with LUTS with abnormal DRE and raised PSA levels, and MPMRI was pirates 3. So we did biopsy, and 12-core biopsy was done in this patient, that was inconclusive, and patient was referred to us for PSMA PET CT and guided biopsy. And what we noticed, there is a focal lesion in the base of the prostate, and we did biopsy from this focal avid lesion in the prostate, and it was Gleason score was 3+3. Now coming to the take-home message, transgluteal PSMA PET guided biopsy is feasible, it is safe, has excellent diagnostic yield as compared to other method of doing biopsy. It is a highly practical approach in patients with prior negative truss guided biopsy and with PSMA PET positive lesions. It negates the chance of inoculation of the prostate with rectal flora, thus reducing the morbidity due to bacterial infection. the finding of our results pave way for PSMA PET CT and upfront PSMA PET guided biopsy for early diagnosis of the prostate cancer. And now coming to our history, India got independence in 1947, and the first rocket was launched from Thumpa, and we transported our rockets on the bicycle and bullock cart. And in today, we were celebrating Azadi Ka Amrit Mahotsav, and we are transporting our rockets on the big trucks. And now we started our biopsy venture in April 2013, and we did first biopsy from a very superficial inguinal lymph node. It is hardly need PET guidance biopsy. And now today we are doing biopsy from the very deep-seated prostatic lesion, entry place lesions. And this is our graph. And now we have done around 7,000 PET CT guided biopsies and around 500 PET guided prostate biopsies. And this is a small video of a patient. He will share his experience.
Thank you, Dr. Rajender, for your illustrated and nice talk in new area, that is PSMA PET guided transgluteal biopsy, which has got almost 0% incidence of UTI or urosepsis. Any question, please?
Thank you. In one of your slides, you showed about the comparison between PSMA PET CT and MRI, right? But the biopsies all had pyrite 2, 3, 4, 5.
Yes.
So all the cases you did a multiparametric MRI, right?
Yes, sir.
And then you compared PSMA PET CT with MRI. So was it a PSMA PET guided targeted biopsy, or it was a MRI guided targeted biopsy?
Sir,
Because all the biopsies were pyrite 2,
yes,
3,
yes,
4,
yes,
5,
yes.
and then you compared PSMA PET and MRI. So exactly, was it targeted PSMA or it was a MRI targeted?
Sir, in upfront patient presenting with LUTS, we did MPMRI, and we divided patients in the two categories. First category is for PSMA PET guided biopsy, and then second category MRI fused trust guided biopsies. It's a controlled trial.
No, fine.
Yeah.
First, the targeted biopsy were taken with PSMA avid lesions?
In
or it was
PSMA arm, we did biopsy under PSMA PET guidance. In the trust arm, we fused.
So then why they were, in this column you had pyrite 2, 3, 4, 5, and then you compared the two. So I couldn't understand that
In
slide.
pyrites 2 and 3, under MPMRI, and trust guided biopsy was not done because the lesion was not equivocal on MPMRI, so biopsy was not done in those patients. In pyrites 2 and 3 lesions, PET was done. They were taken to the PET arm, and PET was positive in 24 patients, and out of these 24 patients, 19 had prostate cancer. In pyrites 4 and 5, patients were divided into MPMRI directed trust guided biopsy group and PSMA PET guided biopsy groups. And in those patients, biopsies were done in MR directed trust guided biopsy. Biopsy were done in pyrites 4 and 5 lesions, and what we found, the sensitivity was less as compared to PSMA arm. In pyrites 4 and 5 lesions, PSMA PET had shown higher detection rate as compared to MRI directed US guided biopsy.
But what we know exactly is for local staging of the prostate cancer, probably multiparametric MRI is a better tool than PSMA PET. PSMA PET is for systemic staging of the disease. So do you think you will pick up better with a multiparametric MRI for localized prostate cancer, where exactly the cancer is? And if you do a targeted multiparametric MRI kind of a biopsy, then it would pick up more lesions than the PSMA PET avid lesions. Yes. Because PSMA PET avid lesions is not a good tool for staging the localized prostate cancer.
Sir, if PSMA PET is positive, means the disease is there. In 8 to 10% of the cases, PSMA PET may be negative. I'm not saying that all prostate cancers are PSMA PET positive.
Find out the site, the target, which is better, multiparametric MRI or PSMA?
No, even PSMA PET guided biopsy, you can quite well localize the lesion, where it is laterally, it is anteriorly, it is posteriorly. Even on MRI, there is gray area. In MRI, you are working in gray area. Here, you are working in whether it is there or not there.
No, Dr. Rajinder,
Yes.
can I clarify one point?
Yes, sir.
The PSMA positivity rate
Yes.
depends upon, there have been studies have been done,
Yes.
depends upon the MRI reporting also, 1, 2, 3, 4, 5. What is your comment on that? Because your 2, 3 low significant cancer may not be picked up by the MRI. So similarly in PSMA CT will also pick up the high risk prostate cancer, not the low risk.
Sir, comparing the MRI with the PSMA PET CT, MRI in the pyrites 2 and 3 lesions, MRI is equivocal, and we cannot say whether this patient is having cancer or not. In those cases, PSMA PET have definite role. And in our study, second study, what we found, in 24 patients, 19 had prostate cancer. Obviously, there were, of these 19, 8 had clinical significant prostate cancer. I'm not saying that all are clinical significant, but out of 24, around 8 patients had clinical significant prostate cancer. That is a good number.
Okay.
How many? Now, how many were false negative? How many you had positive on a PSMA PET, and how many were not having malignancy? What is the percentage?
PET
You had total of 24 cases.
in
50,
70
out of 76, all have been PSMA positive or pre-biopsy. How many of them are negative on biopsy?
In 56 patients, what we got is 54% were diagnosed to have prostate cancers, and two had PSMA was increased, and we did biopsy from those sides, and that they turned out to be chronic prostatitis.
Let me get the thing. If out of 76 biopsies, 54 were positive.
54 were PSMA, 56 were PSMA PET positive. Of these 56, 54 were turned out to be prostate cancer, and 2 were chronic prostatitis. And in those cases, there was resolution of the PSMA uptake on follow-up images.
We can discuss later on after the talk. Now I will request Dr. Adit Sharma for next talk. Please. क्या है next talk क्या है? Multi-parametric MRI and PSMA PET guided biopsy.
Very good morning to all of you. At the outset, I would like to thank the organizing committee, Professor Olak, and the scientific committee of North Zone Society. Dr. Sabnis just barely touched upon that there is now talk going around in circles that we may totally omit biopsy. So when I started to prepare this talk, whether multi-parametric MRI in conjunction with PSMA PET CT, can we actually go ahead and omit biopsy and go ahead with the procedures, whether you want to go for a radical prostatectomy, radiotherapy, or ADT chemotherapy? Let's see. I have nothing to disclose apart from that I am a man of scientific temper. And when I started preparing for this talk, I realized that we as surgeons are dealing with solid organ malignancies. When we look at a CT scan and we identified that there is a lesion, there is an enhancement pattern, certain amount of Hounsfield unit enhancement is there, we go ahead and decide whether it's going to be a partial nephrectomy for this patient, it's going to be a radical nephrectomy for this patient. Looking forward, you look at surgical oncologists, your GI surgeons, they look at a lesion in the pancreas, they decide that this is malignant here because certain CT Hounsfield units enhancement is there, certain other characteristics are present, and you can go ahead and do a Whipple's procedures, which is a very moribund procedure to begin with. I go ahead and do a lap radical nephrectomy based upon my CT finding, very high probability of it turning out to be a oncocytoma, central scar is present, it turns out to be oncocytoma, it is acceptable because the entire kidney was already destroyed. If you go back to the literature, radical pancreaticoduodenectomy has been done for almost 7 to 10% of the patients who had a benign lesion in the pancreas. Now look at this scenario. A 72-year-old gentleman, this was last OPD, comes to me with lower urinary tract symptoms, hematuria, PSA of 331. DRE showed hard nodular prostate reaching up to the lateral wall. I ordered a PSMA PET scan, finger-guided biopsy. I'll ask my chairpersons, sir, do you start tablet bicalutamide or anything to begin with in the OPD at first visit itself? Yes, of course. The answer is yes, because the pre-test probability of this patient having a prostate cancer is very high. You don't wait for a biopsy before starting a treatment for this patient. So what stops us from doing a radical prostatectomy for patients whom your rectal exam is saying that it's likely to be a prostate, your MRI is saying it's a Peyer's 4-5 lesion, very high likelihood, your PET scan is saying it's a SU max of 8 or 9, whatever it may be. The problem is that you don't want your patients to end up with this. It's very easy for you to counsel your patients about you're going to have incontinence, you're going to have erectile dysfunction, you may have hematuria, you may have transfusion requirement which may go up to 3 to 4. Be it radical prostatectomy, be it radical radiotherapy, bladder neck contractions and what not, radiation cystitis. So you are afraid of those complications before you embark. So you need a short thing that yes, you have cancer, now I can counsel you for these complications. So are we in an era where we have decreased our complications and we can say this, yes, this is a imaging. In all probability, I am saying 90% it is to be cancer, 10% it may be something else, and maybe you have to live with these complications. This was a systematic review which showed that there was lower blood loss, lower transfusion rate, and less hospitalization duration. Mind you, there was incontinence rate, erectile dysfunction, and all these complications remain still the same, whether you are doing it robotically or you are doing it with the open approach. So what has changed? 94 PSA came, the early detection started, then came the molecular imaging. We started saying trust guided biopsy, we are going up front. We need a multiparametric MRI at 6 weeks down the line so that we can localize the lesion, we can plan our surgeries better. Then we said we need a multiparametric MRI upfront. We don't want to wait for 6 weeks. Now we have another kit, as Dr. Rajendra showed, PSMA PET scan. Whether combination of these two imaging modality will lead us to offer radical prostatectomy upfront. Now we have another toy to play with, it's the robot, which is giving you, if not better incontinence, better operative times, better hospitalization rate, and better blood loss. So much so that if you're removing a localized CA prostate which is small in size, you say that I have removed a blood on table. So what are the pitfalls? Why are we so afraid? If you search for pitfalls for the existing imaging modalities, that will be multiparametric MRI or a PSMA PET CT, not every center has or equipped with people like Rajendra sir. We have Dr. Ujjwal who are dedicated to uro-oncology and they are doing dedicated work and they are going to tell you, yes, this is a prostate cancer, this is likely to be a granulomatous prostatitis, this is likely to be a benign nodules. So if these two modalities are combined and if you are able to predict that yes, this is a cancer, you may offer a patient upfront surgery or upfront radiotherapy without doing a biopsy itself. So if you look at the pitfalls, for primary diagnosis of prostate cancer, you have basal hypointense zone, ectopic BPH nodules, granulomatous prostatitis, and a T2 hypointense lesion. You can see here, I have just kept 3. If you look at pictorial articles which are there, one is granulomatous prostatitis, one was benign nodule, and one other was a prostatic abscess. So these are the limitations which are limiting you before offering a radical prostatectomy or a radiotherapy upfront without doing a biopsy in these patients. Same holds true for prostate imaging. If you look at this PET scan, this is on the left-hand side of your screen, this is the PET scan of the same patient. One patient has been given a PSMA PET scan where you can see the salivary gland have lighted up, you can see the kidneys have lighted up, and you can see a lesion in the prostate as well. But the same patient has been given a DOTA PET by mistake, and you can see the thyroid is visible, the pituitary is visible, the GI tract is visible, but you cannot see the prostatic lesion. So this is what, in a nutshell, is the pitfalls of prostatic imaging. You have other false positive and false negatives like fracture, osteomyelitis, Paget disease, inflammatory conditions like tuberculosis, sarcoidosis. So these two modalities are also not free from what we can say their pitfalls. Now what happened of late, these are the trials which came out and say that they told us that PSMA PET CT fares better than multiparametric MRI in detecting localized lesions. And then came the primary trial. This was the prospective multicentric trial, and they looked at the additive predictability, additive diagnostic value of PSMA PET CT combined with MP-MRI and said, if you have a grade group disease, I can tell you, if we combine your multiparametric MRI, which is showing a grade 4-5, Peyer's 4-5 lesion, and your SUV max is more than 8, you are 100% likely to have a prostate cancer. So for a grade group disease, which is a clinical significant prostate cancer, I can give you an answer with 97% sensitivity and 100% specificity, and they advocated and paved the way doing a radical prostatectomy upfront in these patients. It's not new. It was 2015 where a case report was reported, radical prostatectomy without a prostate biopsy in Pirates 5 lesion based on 3T multiparametric MRI alone. At PGI, because we had an access to this data in which we were doing a multiparametric MRI as clinicians and we were sending patients for targeted biopsy to Dr. Rajendra, we looked at our data and we included the patients who had elevated PSAs, finding on digital rectal examination and having localized disease on imaging. And we subcategorized these patients based upon they underwent radical prostatectomy or not. So we picked up the patients who underwent radical prostatectomy, and 65 of these patients underwent radical prostatectomy. Out of these, 5 patients were clinically negative for prostate cancer. These are baseline demographic. The clinical staging you can note, T1C and T2A comprise almost 90% of the patients, and all these patients has Pirates 4-5 lesion on multiparametric MRI. This is the ISUP grading. About 25% of our patients were grade group 1. This is the most flagged because when we are submitting this, they are asking the Western people, they are now shunning away with grade group 1 and they consider clinically significant prostate cancer as grade group 2, and this was a limitation because this could also be a pathological bias and these slides may need to be reviewed. But if you look at the SUV max based on the Gleason grade group, you see there is a progressive increase in the SUV max, which is almost quite linear. And when we look at the ROC curves for patients having Pirates 4-5 lesion and the SUV max cutoff was about 8.25, we found a sensitivity of 82.8%, specificity of 100%, and the area under of curve almost 0.876, which is a very good area under the curve. So we concluded that a combination of Pirates 4-5 lesion on multiparametric MRI with a SUV max of 8.25 is very, very highly accurate to predict prostate cancer. Of course, you need to do it in a randomized control fashion before you can actually predict or say that. These are the 2 trials which have come up, which are going in circles. The left-hand side was published in European Neurology. It was a retrospective cohort study of 25 selected patients. We also discussed in our journal club and we were like taken aback that what is going on. But then came this prospective study with almost 67 patients in which they have done away with the radical prostatectomy without a prior biopsy in patients which are quotes highly suspicious. Highly suspicious means your pre-test probability of getting a prostate cancer is going to be high. That means your DRE is conclusive, your PSA is conclusive, and your Pirates is 4-5. In those patients, if you have a PSMA PET scan positivity, you may go ahead and do a radical prostatectomy, and that's going to be foretold eventually in maybe randomized control fashion. So maybe we are going to establish a biopsy-free pathway eventually. This was Trexit. I think Dr. Dharmendra talked about it. This was Trexit 2020. The Brexit was going on in UK, so they picked up from there and they said that let's do a transrectal exit and let's move to transperineal. What I am advocating is eventually, maybe 2 years, 3 years down the line, we are going to have a Brexit or a Brexit, which we are exiting from prostate biopsy, especially for patients who have very high likelihood of having prostate cancer. And what future beholds, maybe we are combining the molecular imaging with a point of care test, which could be a circulating tumor cell, maybe in urine or in serum, and you are going to tell your patient that yes, you are very likelihood of having a prostate cancer, and you are going to need a procedure, maybe a radical prostatectomy or a radiotherapy. Thank you so much for your patient hearing.
Thank you, Dr. Aditya. So we are running short of time, and any question could be taken up afterwards. Thank you very much. And thanks all the speakers. We have seen all the routes of prostatic biopsy, and in spite of low specificity of transrectal biopsy, most of the centers are performing truss-guided biopsy only, because PET biopsy, MRI scan, they are not available in periphery. And in spite of low specificity, solace is many men suffering from prostate cancer, they do not die because of cancer. Thank you very much all.
Thank you, sir.
Thank you.
Thank you, chairpersons. May I call the next chairpersons, Professor S.K. Singh, sir. Dr. Sumit Devgan, Dr. Shalendra Goyal, Dr. Ashish Jindal, Dr. Avinash Srivastav. Sir, Professor Singh, sir. Okay. Sir, sir, chairperson, आप हैं sir. Sir, there is a slight request. There is a request from Dr. C. Mallikarjun, sir, that he wants to present his talk first. Sir, please chair the session, sir. Please.
किनको बताना है बोलना है या आप बैठ जाओ ना साथ में हाँ गुड मॉर्निंग टू ऑल ऑफ यू आई थिंक दिस इज द biopsy the initial step has been taken for further proceeding for the things now yeah so we have now yeah so now we have got video session for again semi live on three there are four speakers yeah so one is for open second is lab by Mallikarjuna and robotic is by Dr. Siddharth Yadav and then Dr. Dogra will be talking on how to preserve the continence in patient of undergoing radical prostatectomy because Dr. Mallikarjuna my friend has to leave early though I offered him he can visit my home and I can offer him something to take from this region to his region but unfortunately I am not going to accompany him this time I have to stay here up to 2 o'clock so I think Dr. Mallikarjuna doesn't need any introduction to any urologists of the world. I should not be exaggerated. It's the reality. The reality, and I feel very proud of telling that he has been my batchmate, and we maintain our friendship till today. So, Dr. Mallikarjuna, please.
Thank you. Thank you, Shravan. I take everything which is liquid, not solids, what you offer. Anyway. Thank you, Northern USI, for giving me this opportunity. Thank you, Baldev, for inviting me to be here. And I had a wonderful day yesterday demonstrating one of my favorite surgeries. Well, today's talk is being hilar tumors and laparoscopic nephron sparing surgery. One of the very, very difficult procedures, what has been rated as difficult, which I don't really consider them to be the most difficult. In fact, one of the tumors which was done by Ravi Mohan yesterday was much more difficult than what I usually see, hilar tumors. It's been, I don't know, I'm not arrogant to say this, but I don't really believe in these scoring systems, which possibly appears to be good to analyze amongst a group of people, but not for individual purpose. So to understand that it is difficult, okay, fine, some sort of a scoring is necessary, and these hilar tumors have been rated as one of the most difficult tumors, in fact. A proper radio mix is the most important thing. Unfortunately, in our scenario, majority of the people do come with a CT scan already done by us. But in these sort of a tumors, don't even hesitate in getting a repetition of a CT scan with a good angiographic phase to understand the real vascular anatomy related to the tumors and distribution of the tumor to the vascular anatomy. So this is one thing which we need to see. And if you look at where all it can be in three places. One, anterior hilar or intrahilar or posterior hilar tumors. Well, the 3D reconstruction and model, I don't know, it helps definitely to understand the anatomy, but again, you get inside with a magnified view on a laparoscopic or a robotic way, you should be able to see it better. Well, an intraoperative assessment with an ultrasound is one of the most important and necessity tools in managing these hilar tumors. Understanding it either where is the tumor, what is the relation with the vasculature, is it anterior to the vasculature, posterior to the vasculature, between the pelvic system and the vasculature, or posterior to the pelvic system, is to be understood much, much efficiently before, and a color Doppler will definitely add to the advantage at that point of time. How do you proceed? I don't think it is a very simple way. There is a simple existing plane, natural plane in the hilum. So it's an existing natural plane. You've got a lot of structures which are interposed in this area with vasculature, pelvic system. But there is a natural existing plane which can be dissected upon. So a transhilar approach is the only thing which is going to be effectively efficient in these patients. careful dissection of the vessels, selective clipping of the vessels, individual ligatures to the vessels, avoid random suturing of the base like what we do. It's not an inner rhinorrhaphy doesn't exist in these tumors, because there's nothing like inner. Everything is exposed. Vasculature will get into the inner rhinorrhaphy. So cortical approximation as and when necessary, and management of the dead space. 3 small tips which I would always think about is avoid vein clamping when you're doing hilar tumors. A distended vein helps you in dissecting the tumor away from the hilum. Number 2, posterior hilar tumor I would rate is the easiest one to do, because you're all familiar with a beautiful gynvalet plane, which we always did it when we were doing a pyelolithotomy. So lifting the tumor away from the sinus area is going to be very, very easy. Intrahilar, I'll show you a video wherein it will be your own surgical principles which you adapted during your staghorn surgery, open surgery, can be adopted in that intrahilar tumors in a posteriorly placed situation. Ports are standardized. I don't think I need to tell about this in August gathering. And hilar tumor anteriorly placed just in front of the vasculature. I'm just showing a video of it. After identifying the vessels or dissecting the vessels, I would say, and that is a dissection which is being done on an anterior surface of it. This dissection starts inside the hilum first. Don't clamp the vessels, nothing do. Start dissecting the tumor away from the vein, and you'll start small vessels which can crop up into the tumor directly, which can be clipped. So there can be one artery, there can be multiple arteries. Sometimes an artery which is not supplying the hilum also tumor also can be clipped because it is coming in the way. You see this? This is one of the arteries which was supplying the tumor is being clipped, and the rest of the thing is left alone. So it is your discretion at that point of time when you start dissecting. You may end up in placing multiple clips to those veins, etc. Sometimes overtly more or sometimes less. At one point of the time, you start opening into the vein and you stop it at that point of time, and you finish that dissection at that point, and then that's it. That's a vein which started bleeding. So you clip it and it still bleeds. Okay, you stop it there. You can't dissect any further. So you can't dissect. Understand the margin of the tumor very efficiently on an ultrasound. See the way you can cut on, and then clamp the artery. I don't clamp the vein, as I said, and then divide at one side of the hilum. Start cutting onto the one side of the hilum on the margin of the tumor where you found it on an ultrasound, and get into the sinus where you have dissected already. So that is the plane where you start moving upwards now. So you start looking at some of the vessels which have been supplying, which are clipped or not clipped, and small probably a calyx which can come in the way, which need to be a minor calyx which need to be clipped. You will not see a major calyces here. So it's minor calyces which need to be clipped. So you start lifting this tumor away from the hilum and go cephalad. So you may see as you pass towards the side, towards the lateral margin, you hardly find any vessels. It is nothing but an attachment to the kidney parenchyma, and there is a sinus fat which comes into the plane. So this is how the excision is completed. So that's an excision of the thing which is completed. Well, this is general for whether it is enucleatable tumor or non-enucleatable tumors. The concept can be the same. So you'll have a big dead space there with multiple clips. How do you handle these things? Majority of the times you see the small vessels which you opened, you will be able to identify them once it is excised, and then try to put multiple interrupted fine clips, fine sutures, either with Vicryl. I would prefer a Vicryl. And at the edge of the kidney parenchyma, you see multiple veins coming in towards you, and that edge need to be tied. Need to be multiple ligatures can be placed. So at one point of time, you see this, we are giving a Valsalva maneuver. The anesthetist is giving Valsalva maneuver. That will show the retrograde bleed from that veins. So you see that retrograde bleed, and then identify those areas and take one or two more sutures in that area. So that is a completion of it. And then I always take a small fat pad from the perigerotal fat pad and get it onto the center. The reason why I take this is because you have multiple sutures there, and the multiple clips there, they get stuck to the fat, and once I take an inner rhinorrhaphy, which is not going to be coapting completely, but it is going to be a little hemostatic, and that pushes that fat pad onto the anterior surface and fills the dead space. So it is not going to coapt it completely. If it is possible, it is fine. If it is not possible, don't do it. Just leave it a gap between it, and then take it as much as you can, and leave a gap there, and this fat will create a space there and fixes these clips, which are multiple clips which are being placed at that point. So when you come towards the hilum, beware and see that you are not going to get into very tight there. So that let it be a little loose, and so that there is no compression onto the veins, and venous obstruction can happen because of over tightening of that area. And we declamp the thing and see for any bleeding for some time. A good vasculature, vascularization which has happened, and we keep a drain and complete it. So that is a typical way of an anterior hilar tumor being done. The second thing is a posterior hilar tumor, supposed to be the most difficult tumor out of all. But I would feel this is the most easiest tumor when compared to anterior hilar tumor, because of a simple fact that what we do in these cases is mostly we just mobilize the kidney completely. This is a polar flip which we have published. The upper pole comes towards the lateral aspect, and the lower pole comes towards the medial aspect, because upper pole is already 30-degree tilted. What all you need to tilt is another 60-degree, and the lower pole is there. And that's a beautiful Gilbert plane which can be dissected between the tumor and the pelvis. And you can see the posterior segmental artery which is supplying into the posterior segment. Identify that branch which is supplying it, and then clip it. And that is going to be completely vascular at that point. And now either you take a Satinsky or you take a Bulldog. I took a Satinsky because it gives a stability for the kidney to stay on it. So you put it and then push this polar flip, you do it again, and the lower pole goes up, and then you complete the excision of the tumor now. And it's a simple, somebody is holding it, on the assistant is holding it, and you start excising it. You can do a good enucleation if you are very confident and a good ability to had an experience regarding renal tumors before. So that starts excising, and you don't hardly see any vasculature there. If you see the anatomy of the vascular system, you hardly see anything. It is only one signal artery, that is a posterior segmental artery, which descends out across the posterior segment, and that is already clipped. So you can excise that thing, and you will have one minor calyx which comes into the posterior segment, which can be clipped or even sutured. So that is the excision of the posterior segmental tumor. And the same principle, you take one or two sutures. You don't need much of sutures here. You take one or two sutures for that vascular control, and then close the defect. I don't think there is much in it regarding what I said, I already said. In fact, this is one of those old videos, but now of late, my suturing has gone. The amount of suture which is taken in the parenchyma, it comes just around 1 centimeter from the cut edge. Because once upon a time, it was that overzealous attempt to have a good hemostasis. We used to take a big bites, but it's not anymore. So you put the position, kidney, put the position back into the same place, open the clamp, and then do a small rhinorrhaphy with the Zerota which is there onto anterior surface to the lateral abdominal wall. That is the posterior hilar tumors. Coming to the intrahilar tumors, this is one of the most difficult tumors to handle. It's a completely intrahilar. You see an MRI, it's a CKD patient MRI, you see where exactly is the pelvis, where exactly it is located, but it's still completely intrahilar tumor. So how do you go about? Okay, that's an intrahilar tumor. Renal score is the highest. So what I would advise you in this patient, if this has been there anterior to behind the vasculature, and anterior to the pelvis or even posterior to the pelvis, doesn't matter. What you do is going to be, after dissecting, understanding the anatomy, clip, and then do a posterior radial nephrotomy. This is what we used to do when we are doing sometime in our when we are doing stag on stones. We used to give a pelvic cut and goes into the lower calyx, and then so it's a posterior radial nephrotomy, where between the junction of the lower segment and the posterior segment, lower pole and the posterior segment, given an incision that opens up the sinus completely, and I'm started enucleating that tumor completely. You see that inferior calyx which is stretched over across it. I haven't opened the inferior calyx, but I could access into the hilum very clearly, and we are able to see the tumor which is very well and easily enucleatable. And we are excising to the anterior part. Be careful that you are not going to excise any vasculature there. Stay in that sinus fat only, which usually shows some element of desmoplastic reaction. So you need to have a cut rather than enucleation. So that is enucleated with a small sinus fat attached to it also, and that is after enucleation. You see that blood vessels which are going into the tumor, and you start making a multiple small Small bites, not a big bite. If you take a big bite, you will go through into a deeper part and take the vasculature anteriorly also. Small bites with a 3-0 Vicryl and take 1 or 2 sutures. If there is a small injury to the calyx, just repair it and then close it the posterior radial nephrotomy. And this is an access for intrahilum. So if you want to access into the hilum, flip the kidney, make a radial nephrotomy. And any from the lower pole upwards, you can access the hilum without any difficulty. So this is a posterior radial nephrotomy which is completed, and you open the clamp. You don't need any dead space because it's already dead space is already covered with this suture. Open the clamp and reposition it. So look for a bleeder. There's hardly anything there. Then reposition it completely. So this is a posterior radial nephrotomy. Take home, I don't think there is anything new for this sort of hilar tumors. It is same. I don't think there is no change. But we need to understand the feasibility of excision and possibly the competence. Never compromise in your approach. I would say this is one of those patients where I had to place so many ports because I was not comfortable in some steps either on suturing or in dissection. So no compromise approach. Thank you.
Thank you, Dr. Mallikarjuna. I think needless to say, I need not explain why the presence of Dr. Mallikarjuna is solicited everywhere. And I thank you very much, Dr. Mallikarjuna, for accepting our invitation and making this workshop and adding to the success of this workshop.
Thank you. Thank you, sir.
Thank you very much. Have a nice journey and safe journey back home. Bye.
Can I have one thing to say just?
Yes, please.
Just my recent experience, there was a big hilar tumor. And I didn't do it laparoscopically because I am not probably an expert in that case. So I did it open. So most of these tumors are circumscribed and can be easily enucleated. I found these hilar tumors so easy to operate by open because you have that tactile sensation and the tumor gets automatically, by this pressure, removed. So these small hilar tumors, I think by open approach, those who are not very expert in robot or lab for hilar tumors, it's a much simpler approach.
I have a small comment on that. I think basically the surgical principles don't change, whether we do open, lab or robotic. Easier or difficult, what I would say rather is, if you see the radiomics, you see the picture, if it is a very encapsulated, nice, defined tumor, go towards enucleation, which happens in some patients. There are some tumors where the definition of the margin is not there. Never try to enucleate, just excise by the side of the tumor. So I think radiomics plays a lot of role, and reading into it, whether what sort of a tumor you might be seeing inside is going to play a major role in success of the surgery.
So my major point was that tactile sensation helps.
Absolutely helps.
Thank you. Thank you very much.
Thanks a lot, Mallika Sons, for giving such a beautiful presentation. Now I call up on stage Dr. Amlesh Seth for presenting a video on the nephron sparing surgery in hilar tumors via the open route.
Thank you, organizers, and I thank Dr. Baldev Singh Aulak especially and Dr. S.K. Singh. Dr. S.K. Singh rang me up a couple of months ago and said that I have to present a video on open partial nephrectomy. And I said I don't have a video, but in these 2 months I should be able to get at least one. And by chance I had only one case that was done open and another case that was converted from robotic to open. So first I'm going to present the video of the case that was done open, and then I'll just show one slide of the case that was converted from robotic to... I don't have to talk about nephrometry scores and all because that has already been talked about by Dr. Mallikarjun. And I'll re-emphasize the 2 points which Dr. Mallikarjun has already said. Number one is that the surgical principles have to be followed, the anatomy remains the same, and whether one does it by So whether one does it by the open technique or by laparoscopic or robotic, the surgery remains the same. It's just what you are more comfortable with and what you in your hands is likely to give better result to the patient. So this is a patient who had a 7 centimeter lesion, which you can see is going into the hilum, and it has a long attachment to the pelvis and the upper ureter, and there is a parenchyma all around. In the lower pole area, you can see that there is parenchyma all around, so it is going deep in the sinus. So we decided to do this patient by open surgical technique, and as has already been emphasized by Dr. Mallikarjun, the easiest plane for hilar dissection is the Gilbert plane. We all have done hundreds of extended pyelolithotomies, and once you enter that plane and dissect the plane between the pelvis, you are deep in the hilum, and you have come practically all around the tumor, and you can do it reasonably safely. So the incision given for this particular case was not very big. He was a lean and thin man, and therefore the other thing is, open surgery is becoming so uncommon that now there is a thought process that is going on that whether there should be a fellowship in open surgery after an MCH. There are fellowships in laparoscopic surgery and there are fellowships in robotic surgery, but this thought process is also coming up that whether people who are already MCH should go to centers or to surgeons who are doing a lot of open surgery and get trained in open surgery or not. And So now this is the plane in which one has to go. Outside the Gerota's fascia, and this plane in a virgin case is a very well defined plane. So all that one has to do is preserve a thin layer of fascia over and once you have mobilized the kidney, the renal artery pulsation can be seen from a distance, and then one can actually just dissect the artery behind, and this is the anterior mobilization separating it from the peritoneum and the duodenum and the colon. So you can see this plane is so well defined, and there are very, very tiny vessels which can very easily be fulgurated, and it's actually in fact a pleasure dissecting it in this plane. So here it is separation from the duodenum. So you can see very, very tiny vessels from the duodenum, and once you have lower half of the kidney in your hand, I have not mobilized the upper pole. So now I have opened the Gerotas, and this is the dissection of the ureter, which is a very standard dissection which can be done by a first year resident also. And then one just needs to keep on progressing upwards in the Gilbert plane. For upper polar and the interpolar tumors, you have to dissect the artery also. So once you have dissected the artery, once you at the origin, then one can, the way one is dissecting the ureter, one can keep on going into the hilum along one of the surfaces of the artery and keep on tracing all the branches. But in this video, all that I am showing is the dissection of the hilum in the Gilbert plane, because that is what was required for this particular patient. And normally in Gilbert plane, there are no vessels from the pelvis or the ureter, but in this case, because of the tumor, there are some tiny vessels which are actually coming from the communications between the pelvis and the upper ureter and the renal parenchyma. The main renal vessels, fortunately, or I would say fortunately or whatever, they were going through the parenchyma into the tumor, and no major vessel was encountered going into the tumor. But whatever fat was there, that was doubly ligated and divided, and so one has gone in the deep in the hilum. So this is the posterior dissection. Anteriorly, the vein was just having a gap of about 2 or 3 millimeters between the tumor, but the vein was away. So anteriorly, there was no deep dissection required into the hilum, and posteriorly, there was this deep dissection that was done in the hilum. So you can say this pelvis is getting separated. So the pelvis has more or less, the tumor has been more or less lifted from the pelvis. And now doing this ultrasonogram, there's actually a deep tumor extension. So a heminephrectomy was required for this particular patient. So there is a surrounding parenchyma with a tumor inside, and there is a big exophytic component also, but there is a reasonable endophytic component, and therefore a heminephrectomy has been planned, practically a horizontal kind of a nephrectomy. And so after the artery has been clamped, and during the resection, one can see the branches of the artery. One can, for the time, one can just put some hemostatic artery forceps. The vein needs to be sutured. So as soon as a tributary was seen, partly opened, the suturing of the vein was done before complete and the pelvic ileal system, whatever was seen, it could be seen very easily, and even the pelvic ileal system was also repaired before complete dismantling or complete. So you can see that this hilar suturing has been done just before complete detachment. And now after this complete detachment, there is very little that remains to be done. And in a matter of exactly 17 minutes, not only was the partial nephrectomy completed, but the inner layer of suturing was also completed. So this is rhinography after removal of the clamp, and there is hardly any bleeding. And as was shown by Dr. Mallikarjun, a pad of fat has been brought into the hilum so that the pelvis and the ureter, they do not get attached to the raw parenchyma. So there is some kind of a fat covering over the bared part of the pelvis. Unfortunately, there were no vessels. There were just some venous tributaries which were controlled very easily. And the arterial tiny vessels which are coming through the parenchyma, they also could be seen before the detachment of the kidney, and they were point controlled. And this is now wrapping the whole area with the pad of fat. So the main advantage of open surgery is the speed, and in a case which is difficult and you feel that in laparoscopy or in robotic you may take a time which is beyond the limit, open surgery is definitely safer, and especially in a patient who has borderline renal function with a creatinine of 1.5, 1.6, although that was not the situation in this case, then sorry, how do I escape? No, I just want to finish this. One second, here it is. Yes. So, this is the second case which I started robotically, but I had to convert. A 48-year-old gentleman presented with incidentally. So this is the ultrasonogram which is showing a 4.7 into 3.6 again left-sided lower polar mass. It was well circumscribed. Yes, this is a point again which which has already been made by Dr. Mallikarjun, and which I would like to re-emphasize. You know, it is most of the times the tumor is well encapsulated, But there are occasions when it is irregular and there a very wide excision is required, and those patients generally will have a poorer prognosis. And in some of those patients, perhaps it may actually oncologically be better to subject these patients to a radical nephrectomy rather than a partial nephrectomy. So here what you can see is, this is the renal vein and this is the hilar area. And compared to the right side, the hilum is more medial and it becomes more and more medial as we keep on coming down. And it has started facing a little laterally in the lower part. But as per the CT report, there were two vessels. One was the main renal artery and there was an inferior polar one. Again here you can see that there is a good amount of parenchyma all around and there is a good endophytic component. So although it is 4.7, but the endophytic component is significant, but still because there was a separate artery going into the lower pole, we thought that it should be possible to do it robotically, and once that lower artery is controlled, then the excision of the mass should be relatively straightforward. However, what happened was that we could identify two renal arteries, but there was a big vein which was going into the tumor area. If I can point it out, is my cursor coming there? Yes. So here you can see, this cursor is not moving. Here you can see that this bulldog is actually on the vein after opening up. So this is after opening up. We had identified one renal artery here and one renal artery here. So I had put a clamp on this, but still there was a good amount of parenchyma. So this entire thing is the tumor, and the normal part of the kidney is actually higher up. So, and there was this vein which was going into the tumor, and I thought that it could not be dissected very easily, so I felt it is better to open up and do in an open. We have made a small incision because it was already significantly dissected. So therefore, the view that you are getting in open is relatively limited. But after opening up, we realized that there were other arteries also. Maybe these were the branches, and in the hilum, so you can see there is one artery here, one artery here, one vein here, one artery here, and one more artery here. So all these were clipped, and then in the hilum was all actually anterior because it was a mal-rotated kidney. So this is the hilar area, and here in this part of the hilum was dissected, and then the pelvis was separated. And after the pelvis was separated, there was another big vein, which was, this vein was taken care of, but there was another big vein which got partly avulsed after the excision of the pelvis. So then quickly I had to take the kidney, the tumor out, and between my two fingers I had to squeeze the hilum, and when my assistant repaired that vein. So, and that vein obviously needed repair very quickly because it was a big side hole in the main renal vein. And perhaps if I had continued with robotic, and perhaps if that injury had been there, it would have been a major issue. But fortunately things worked fine after conversion. So these are the two cases that I would like to present. Thank you very much.
Yeah, thank you, Professor Amles, because you have been a good teacher, and that's why I imposed that you should start teaching the people at the time when how to do open surgery. Well, you have been doing oncological surgery open earlier. Now you have switched over to for last decade on the robotic surgery. So I think it's very nice. Anybody has any comment to make? Only one thing I have to ask Dr. Amles to you. When there was a venous injury at the hilum, what suture one should apply there for closing the vein?
Yeah,
But I could see that you are applying some other suture, that's why I thought.
Ideally, one should apply 5-O-proline, but because there was a welling of blood, the suture that was available on the table at that time was 3-O-Vicryl. 3-O-Vicryl and 4-O-Vicryl were available, so 4-O-Vicryl, 3-O-Vicryl was mainly used for controlling.
Just to show that I have been very attentive chairperson that
Yes.
time. Yeah. So just
Yes.
anybody had any question
Yes,
and any
yes.
comment to make? Okay, thank you very much, Professor Ramles.
Thank you.
And thank you very much for agreeing to, my request that you prepared video in very short period of time and you could look for the cases. Thank you very much. So now I invite a very talented upcoming urologist, Dr. Siddharth Yadav. He will be talking on robotic nephron sparing surgery.
So, good morning, respected chairpersons. This video was supposed to be presented by Anup sir. Unfortunately, he was unable to make it to the conference. I will be presenting the video on his behalf. It is his, he has operated upon these patients. So the first case today is a 60-year-old male. He had an incidentally detected renal mass. His BMI was 31, and besides that, everything evaluation was normal. It was a 4.5 into 5.1 centimeter mass in the anterior lip of the hilum of the left kidney. And there was a single renal artery with the early branching, and a separate segmental branch was going and draping over the upper part of the left renal mass. So the plan was to do a robot-assisted left partial nephrectomy for a clinically T1B lesion with a renal score of 9x. So the standard port placement for the Da Vinci XI system is in the straight line, and we put a single assistant port of 12 millimeter between the cephalad and the first camera port. So as standard steps, the colon was mobilized. And after the mobilization, we try to reach up to the hilum. So after dissecting the perihilar fat, we reached till the hilum. The vein could be seen now. At the first go, we actually looped the first branch of the renal artery, which was later realized. Now this is the renal vein being looped around. At this point, we understood that the bifurcation of artery is much more proximal. So we took down the gonadal vein. Identify the main trunk of the left renal artery. So perinephric fat was bared and the tumor was identified along with the normal renal parenchyma surrounding it. We always perform an intraoperative ultrasound to see where the tumor is and to identify the planes between the normal renal parenchyma and the tumor, and to see its orientation along with the other hilar structures. After ultrasound, the margins were marked with electrocautery. So for the hilar tumors, we conventionally usually clamp the artery alone in the most of the cases. The tumor was resected with cold shears, maintaining a good suction to maintain a clear field of view. And the calyx got opened and some of the segmental branches got opened while resecting the tumor. Once the tumor was resected, we repaired the PCS with a 3-0 Vicryl. Now we ensure a watertight closure so that there is no leakage of urine in the post-operative period. Usually don't place up stents whenever the system is open. So after the watertight PCS repair, the inner rhinography is performed typically with a 3-O V-lock with a clip placed at one end, and the sutures are run at the corticomedullary junction, taking the most of the vessels, larger vessels which are running in this area. So the needle was taken out on the other end of the parenchyma and a clip was placed here and the sutures was cinched to ensure hemostasis. So the the segmental vein supplying the, draining the lower part of the kidney and the tumor got opened, so it was separately clipped. Similarly, another vein that was seen in the pre-op CT was also identified, which was partly opened and was clipped. So the clamp was then removed, and the second layer was started after that. But there was some bleeding from the hilar area. It was a venous ooze that we could identify. And after dissecting the fat, the renal sinus fat around it, we could see that there was another branch of the vein that was draining the lower pole and was draping the upper margin of the tumor, which was identified and was clipped. This was the segmental vein, which was opened and was bleeding. So a clip was placed here. And then the outer layer of rhinography was continued with a 2-0 V-lock, placing clips on each side to ensure hemostasis. So this completes the rhinography, the outer rhinography. And we usually, not in all cases, but in some cases, we tend to use any hemostatic agent like Flow-Seal or Surgicel. The specimen was then bagged and then removed. This was the final specimen. It is around 4 centimeters. The margins were clear cell RCC. The second patient is a 60-year-old farmer. He had presented to us with the right flank pain. The evaluation was standard and absolutely normal. And he had around 7.8 centimeter mass arising from the upper pole or the interpolar region of the right kidney. It was more lateral rather than being hilar in the location. It was planned for right partial nephrectomy robotic, T1B, or for a renal score of 9A. So the patient had multiple Bosniak 1 cysts surrounding the tumor. So the hilum was dissected and the vessels were looped. Intraoperative ultrasound was performed to delineate the tumor margin. A cyst was seen right very close to the renal tumor. So the margins were then marked in a standard fashion. Any cysts that were present around the tumor were actually opened. The artery was clamped and the tumor was resected with the cold shears. A cyst that was very near to the tumor got accidentally opened. So we ended up finding a plane between the parenchyma and the tumor, and it was resected. The PCS was opened while we were resecting the tumor. So this completes the resection of the tumor. A nice suction is done to identify the open cyst, the open PCS, and there was a vein that was bleeding. The PCS was repaired in a standard fashion with a 3-0 Weichel to ensure watertight closure. And an inner rhinography was performed with a 3-0 running V-lock, running at the corticomedullary region to take down most of the bleeders there. This completes the inner layer, and a clip is placed at the other end, and the sutures are cinched. The outer layer is performed with a 2-0 V-lock within a sliding rhinography technique. And the defect is closed with 3 or 4 sutures. The clamp was removed and the kidney was well perfused, and we ensured that there was no bleeding. So this is the specimen, and it was a clear cell RCC. Thank you.
Thanks a lot, Dr. Siddharth Yadav, for such a wonderful presentation demonstrating the 2 videos. Can I ask you one question? What was the warm ischemia time in the Heiler one?
The first one?
Yeah.
Sir, to be honest, I don't remember, but it would be somewhere around 30-35 minutes. It's an old case, an old video. I don't remember right now.
Okay.
I think actually one should remain conversant with all these things, but yes, it's not possible. So when you have to do nephron sparing, you should adopt to the technique which you are comfortable with. Ultimately, it is the patient safety. But many times I have seen when you offer the patient even robotic assisted nephron sparing, the modern technology, some of the patient may not be willing for that. I remember one of the professor of cardiothoracic surgery from PGI, he has seen Dr. Amlesh Seth doing open nephron sparing surgery. I was very much again fantasized about that. I told him we will do you robotic assisted nephron sparing surgery. He was not willing. Then I told you better go to Dr. Amlesh Seth because he will do nephron sparing better way. And he underwent nephron sparing surgery by open technique. And Dr. Amlesh Seth has been very kind enough to give him extend his courtesy to him. So this is the patient who has to choose. Only that you as a clinician must tell the patient what are the techniques available and what is the merit and demerit of every technique. It is the patient who has to choose, not that you have to choose. So that's the way I do discuss with the patient. I do advise my younger people, please apprise the patient every technique, and then you may help the patient to choose the best option. Thank you, Dr. Siddharth. Thank you very much. Thank you all. So now we have seen all technique, open surgery, then laparoscopic and robotic technique. Now we invite the teachers of the teacher, Dr. Dogra, Sir, P.N. Dogra, sir, who will be telling what are the methods and measures and tips you can adopt for providing a patient or undergoing a radical prostatectomy good continuous mechanism. Yes. So, to Professor Dogra, sir, a good teacher, and a good, very good human being, a very good supportive senior.
Thank you, Dr. Singh, for your kind words and introduction. I really thank Dr. Baldev Singh, who personally called me and asked me that if you can give a talk on this. So I most willingly agreed, said, okay, I will. Friend, you know the most distressing problem of the sequelae following radical prostatectomy is the incontinence. It's not a complication, and this is socially unacceptable as well. And people have tried to ameliorate this problem in various ways, whatever in the best of their knowledge they could think of to help this patient. But it's very difficult to understand the anatomy and pathophysiology of the pelvis, especially after radical prostatectomy. So unless we have a proper understanding of that, it is very difficult to give to a patient what the nature has given. But some measures have been devised on the basis of understanding, which have been found to be helpful to help these patients. Now, what are the main principles of conserving the continence? These are mainly the preservation, reconstruction, and reinforcement. So I will be dwelling on this one by one and see how we go. Now, this is a most important slide, that these are the, I will say, invariable factors which cannot be changed. They are patient-related factors and we can't do much about these, like age of the patient. As the age grows, it's very difficult. We can't achieve the percentage of the continence what we are talking of. At a certain age, certainly less than 70, the chances are more, but if more than 70, the chance of achieving continence becomes less. Then similarly, the volume of the prostate, the size of the prostate, if it is more than 75 gram, especially with the presence of the median lobe, again, it's very difficult, challenging job. Then is the membrane urethral length, that if it is more than 0.5 centimeter, yes, there can be reasonable chances of regaining the continence. Then the body mass index, if there is a morbid obesity in this patient, again, it is very difficult to think of having this normal continence. Then the severity of the lower urinary tract symptom before surgery also plays a role. More severe the symptom, less the chance of achieving the continence. Then a prior surgery on the prostate, be it open, lepro, or endoscopy surgery, and the radiotherapy. In this patient, again, the chances of continence are compromised. Now, what are the aims? Aim is to preserve the bladder neck and to preserve the maximum urethral length. We try to preserve the entire puboprostatic musculo-ligamentous complex. As you saw yesterday, I don't know how many of you attended yesterday's that live workshop in the prostate radical prostatectomy. It was shown very nicely. Then preserve the nerves. Then there are the preservation of the seminal vesicle, how much it plays a role, it's again a question mark. And many people have talked about this, but it is not found of much help. Similarly, size of the caster, duration of the caster, casterless. Some people are just putting a suprapute tube and leaving a splint, but all those things are very, very personalized practice. They are not found a place in the universal practice. Then, of course, the one is the surgical approach, which is the radius sparing surgery, popularized by the Bouchard. Now, reconstruction, all of us are aware of this and is much talked of the Rocco stitch. He was the one who proposed the posterior reconstruction, like the fibrous tissue surrounding the external sphincter complex is attached or fixed or sutured to the proximal dinervillar fascia and the posterior wall of the bladder, as shown depicted in this diagram. This is the video which is showing you this Rocco stitch, in which you can see the dinervillar fascia with the wall of the bladder is fixed to the surrounding fascia around the rhabdoid sphincter. This was popularized by Tiwari et al. They thought that if we lift it as an apron, we do not cut the puboprostatic ligament. We lift them as an apron with from the bladder wall along with the endopelvic fascia, and then at the end of the procedure they are attached to the bladder. So this was their idea. As even yesterday, Mallikarjun was also talking about this arcus tendinous part, that we should spare it, don't damage it, and reconstruct at the end of the surgery. This is the periurethral suspension. It was the Patrick Walsh who popularized initially when he was doing open retropubic radical prostatectomy, and his concept was to compress the dorsal venous complex and also to hinge the urethra, lift the urethra, which will help in maybe play a part in the continence. And subsequently, Patel, when he started doing robotic, he popularized it further and he was doing it on a regular basis. What of late I am told that Dr. Patel is no more following this particular procedure. So I think he must have realized, as we know, it takes time for the water to find a level. So we all are excited in the beginning, but it takes time to find out really whether it was worth or not. This is one of my old videos, probably in the 2012, in which we were dropping this, you can see the tuboprostatic and the fibrous facial structures lifting from the bladder to control the DVC, and then do a periurethral lift with that stitch. See, this is the suture being taken to control the DVC. And then through the periosteum, the needle is passed to hinge this superiorly to give it a support, whatever it is. I don't know, whatever way it helps, maybe it helps to control the DVC, or it prevents the retraction of the urethra. Whatever way you think it is of use and helpful, so one can practice it. This is regarding the gaining the maximum length of the urethra. We should attempt to gain as much length of the urethra as possible. Very meticulous dissection. As even yesterday, Dr. Mallikarjun showed you, he dissected the urethra into the notch of the apex of the prostate to gain the length, extra length. And I must acknowledge some of these videos have been shared by Dr. Anoop, Dr. Siddharth, and Dr. Amitabh Sinha. So this is the one in which we try to achieve the maximum urethral length by doing the meticulous dissection in the apex of the prostate. Now coming to the preservation of the bladder neck. I think this is most important, and many of us cannot do that. You need an art to fleece the bladder from the bladder neck to preserve this. It's not very easy. You have to do a bipolar cautery. Do not do a monopolar cautery and go on peeling the bladder from the urethra to preserve this smooth bladder neck. Internal urethral sphincter like this. So this is called pre-prostatic sphincter as well. So many of time we are not able to preserve the bladder neck because of certain conditions. So we have to really do the reconstruction of the bladder neck.
Just sir, sorry sir. Just very sorry to again draw your attention, Professor Baldev and others. Please be attentive and don't. Hello, Dr. Baldev Singh Olak. Dr. Olak, Dr. Sanjay Surekha, I am just watching. Please be seated. Don't disturb the session here. If you have to do something, please go out of the hall. Thank you.
Well, I have, I think...
Sorry, sir. Thank you.
No, it's okay. Thank you. I move to the next.
That's my duty. I did my duty, sir.
Now coming to the preservation of the neurovascular bundle. As we have been told and emphasized that these preservation of the nerves do help in the preservation of the continence. So one should try to do a nerve preserving surgery if it is indicated otherwise from oncological point of view. And also beside this, the perineal nerve also give a branch, which is a pelvic branch of the perineal nerve, pudendal nerve, beside the perineal branch, which also supplies the external sphincter and helps to improve the continence following this procedure. Now this is the Ritchie sparing surgery. You can see it, that dissection is all posteriorly and anterolaterally. We are not doing any dissection. We are lifting the prostate from the posterior aspect. It's called Bouchard's procedure or Ritchie sparing procedure. And because we were trying to dismantle the prostate and trying to reconstruct the interior complex, then they thought of why not to do this procedure so we don't touch the interior part at all and keep it intact, and this might help. It has helped. Initially, the rate of continence is certainly better, but ultimately at the end of the 1 year or 9 months, the continence rates are almost better, whatever procedure you may adopt. But initial continence part is here is better, certainly in this approach. But you have to be little more experienced and familiar with the anatomy of the pelvis and the prostate and the bladder and the ureter. Otherwise, there is a chance of injuring the ureter. See, you have lifted the complex interiorly without disturbing the interior compartment at all. Well, thank you very much. This was what I have to show you. Main are these issues which are responsible for conserving the continence of the prostate. These are the hypotheses. At least the Rocco stage, if it doesn't help in the continence, at least supporting your anastomosis, preventing the leak, preventing a fibrosis, indirectly helping you to increase the chances of the continence. Same is the periurethral hitch. It is helping you to prevent the retraction of the urethra. So you have a better view of the urethra for the anastomosis. So all these things are helpful, but they need to be proved functionally how much they are really contributing to the continence part, because I have seen my own patient where I done very meticulous dissection, even preserved the apical part of what is shown, the pre-prostatic sphincter. The patient was incontinent, but those who I did otherwise, they were continent. So nature is there, something I think we are trying to attempt to control the damage to the extent what we can understand. But finally it is, I think nature is a great, nature will help those patients in which we are inflicting this kind of injury. Thank you very much.
Thank you, sir. Thank you, sir. Any comments from the floor? Since we are running late, I would like to...
I have finished before time, I believe.
Sir, you have finished in time, but we are running late, sir. We
Okay,
are running late. I thank everybody, sir.
He requires your blessing to finish it on time.
Thank you.
Now we proceed to the next session, which is the ISU session, sir.
Thank you very much.
And I will request Dr. Gopal Sharma to take over from here.
Good morning, everyone. As a board member of ISU, it gives me immense pleasure to convene this session, which is basically on prostate and kidney cancers. So I would first, to begin with, I would like to thank the organizers, Dr. Olak and Dr. Kamaljit, for making this possible. And without wasting further any time, I would request our chairperson, if Dr. Rajesh Alawat is there, sir is there. I think sir is not there. Then I will request Professor S.K. Singh. Sir, if you can be kind to chair the... Yeah, sir. Sabnis sir as well. Both of you, sir. Both of you, sir. Thank you very much, sir. Thank you. So, our first talk for the day is on locally advanced, which is actually a debate which is on locally advanced prostate cancer. And first opinion, what should I say, our talk would be on radiation therapy by Dr. P. Kannan, who is an associate professor at PGI Chandigarh. Over to you, sir.
Dr. Kannan has a special area of interest, urology, uro-oncology. Right.
So, good morning to all. So first, thank you for the opportunity. So today I have come here to speak in favor of radiation for locally advanced prostate cancer. So what is locally advanced prostate cancer? It's an intermediate entity which we see between localized and metastatic prostate cancers, and it includes any patient who has capsular involvement or seminal vesicle invasion or bladder or rectal invasion and extension to the pelvic side wall. So it can also include patients who have regional lymph node positive, which is a separate category of regionally advanced case. So if you see these locally advanced prostate cancers, they come into the category of high risk group. And if you look into the latest Cambridge prognostic groups, it come into the CPG 4 and 5. So which indicates that there is a high propensity for these cases to result in biochemical, clinical progression and prostate cancer related death. So the two suggested treatment options are, one is radiation plus ADT and the other option would be surgery plus adjuvant RT. So why radiation plus ADT for locally advanced prostate cancer? First of all, for the simple reason, it is effective. So what is the evidence for that? So we have multiple randomized trials. One is the Scandinavian Prostate Cancer Group trial. Another one, we have the National Cancer Institute of Canada trial and the MRC UK trial, which had predominantly included this T3, T4 cases. And then they had reported the 10-year outcomes, which shows a 10-year biochemical free survival of 74%, prostate cancer specific survival of around 88% and overall survival of 70.4%. And this is the another EORTC trial which has compared RT versus RT plus ADT and predominantly included T3, T4 cases around 89%, and we could find the 10-year outcomes as well. And here importantly, if you see the sites of disease progression after this primary RT plus ADT, only 4% had isolated locoregional relapse, whereas rest are all distant. So this is an important point to be noted here. So the combination of ADT plus RT, it improves the disease-free survival and overall survival compared to either RT or ADT alone. So why radiation plus ADT again? So if you go with surgery, surgery may not be able to remove all cancer cells in locally advanced prostate cancer. So usually additional treatment is required afterwards. So this you can see from this adjuvant RT trials, which is the SWOG, EORTC and the ARROW trial, which had predominantly included pathological T3 cases. And if we find that only by adding adjuvant RT, the 10-year outcomes of biochemical free survival and overall survival can be comparable to primary radiation plus ADT. So many people now recommend salvage radiation for these patients. But if you look at the salvage radiotherapy trials, which is the Radicals RT trial, RAVES and GET-UG trial and the artistic meta-analysis, if you see really the benefit would have been missed in locally advanced prostate cancer patients because they have not included such patients, so it is inadequately powered for this locally advanced cancer cases. And another important point to be noted is this locally advanced prostate cancer, when there is a PSA failure which happens, it develops very rapidly. And there is high chance of patient going into clinical progression and developing metastasis. So even before the salvage radiotherapy is planned, or even before we evaluate the response to salvage radiotherapy, patient may progress. So adjuvant radiation is almost always required in locally advanced prostate cancer after surgery. So if you look at, are there any trials which compare this radiation versus surgery? This is one such study which has retrospectively compared using the SEER data between RT versus this surgery plus adjuvant RT in locally advanced prostate cancer. And this showed that 10-year prostate cancer survival and overall survival is better in patients who underwent surgery plus adjuvant RT when compared to primary RT. But if you critically analyze this paper, we can find that it is a retrospective study. So there is obviously scope for inherent population selection bias. So we should always remember that choosing a non-surgical approach when surgery is an option is totally different to a non-surgical treatment in whom surgery is not possible. So other thing is that the patients who have received RT in this, some of the patients have received just for palliative purposes, unlike patients who had undergone radical prostatectomy followed by adjuvant RT. So with palliative RT, the doses and volumes are different from the radical RT. Among the patients who have been treated with radical intent, if you see, they were mainly treated with three-dimensional RT because the patients they have included is from 1992 to 2009. So nowadays the technology has evolved. Now the radiation technique which we use is intensity modulated radiation or the VMAT therapy, which leads to better tumor tracking and dose escalation. So, and the third important point in that paper is that how many percentage of patients in the two groups were eligible for second line of therapy, and how many have actually received is not mentioned, which would have obviously affected the survival. So considering all this, no prospective randomized studies are available to suggest the superiority of surgically based approaches. So radiation plus ADT must remain the best combination of primary treatment in locally advanced prostate cancer. Is that all the reason to recommend? When we look at the adverse events, if you see from the same paper, who has reported the median follow-up of 14 years, the adverse events of urinary incontinence is almost 49% with RP plus HRT, whereas in RT plus ADT it's just 19%. And similarly, the erectile dysfunction rates are higher. And this is another paper which shows that whenever this surgery is combined with RT, the urinary adverse events are more. So that is 37.8%, then followed by radical prostatectomy and brachytherapy and EBRT. So always it is, whenever it's possible, it's always to give a single modality rather than to go for surgery plus adjuvant radiation. So thus it has got a better toxicity profile. So third, from the patient point of view, we have the quality of life outcomes also, which shows that patients who have been treated with salvage radiotherapy, they experience the worsened side effects leading on to worse quality of life with respect to urinary continence, sexual function, and urinary irritative functions. So better quality of life with primary RT plus ADT. So I conclude by saying that radiation plus ADT is the best primary treatment in locally advanced prostate cancer as of now, because it's effective, because it has got better toxicity profile, and we have evidence for better quality of life, and no prospective randomized studies available as of now to suggest the superiority. Thank you.
Yeah, anybody has any question and comment? I think this is a debate, so maybe now we can take in the end.
We will take comments in the end, combined after. So thank you very much, sir, for giving a radiation oncologist perspective for management of locally advanced prostate cancer. So I would request Dr. Swapan Sood to defend the multimodality part. Thank you.
Good morning to all of you, and my thanks to Dr. Baldev Olak and the NZUSI office bearers for inviting me for this talk. And the pedigree of the scientific program is evident from the person who has organized it. I think Dr. S.K. Singh was the scientific chairman, and you can see it's a brilliant academic program, and I'm sure many people are missing out on a big program. But I think Dr. Kanan is from PGI, and you have given me a very partial topic with this debate on locally advanced prostate cancer and multimodality treatment. Now, if सारी जो बंदूक और जो असला था वो दे दिया कानन साहब को, और मेरे को बंदूक दे दी है और कहा कि असला आ रहा है अभी आएगा. So this similarly, multimodality treatment is actually a concept. There is a lot of literature available, but it is not organized, and it is very difficult to actually take out reasonable decisions out of it, reasonable conclusions from the data which it is available. So like what Dr. Kanan said, first of all, we need to set the boundaries of what we are talking about. So whenever the term locally advanced prostate cancer is used, it has been used very loosely in the literature and extends anywhere from T2C or high PSA and all the way till T4 and N1 disease it includes. And there are various people who have included, even the guidelines, international guidelines do not seem to agree what is a locally advanced prostate cancer. But generally speaking, it has now coalesced around the point that high risk and very high risk prostate cancer, which is T3A-B and grade group 4 and 5, and PSA or high PSA is the primary without any nodal metastasis. That is somewhere where it has coalesced the definition of localized or very high risk prostate cancer. Of course, nodal metastasis N1 disease remains a debatable point whether to increase it, especially when it is found after the radical prostatectomy has been done. If you look at the guidelines, which are the most commonly followed guidelines from NCCN, we see that there is no mention of multimodality treatment. Multimodality treatment is as you fly, so you decide which direction in which you are going to do. So as you cannot decide the treatment protocol in the beginning in multimodality treatment. We know a few things about radiotherapy. Dr. Kanan was kind enough to point out a lot of data. We know as we increase the dose of radiotherapy, the response is better. And therefore, you have that 66 gray and then the prostate boost and then the brachytherapy boost, and trying to get that last bit of result in the favor of radiotherapy. We also know that radiotherapy and ADT is better than radiotherapy alone. I think Dr. Kannan proved this point quite clearly. And we also know that radiotherapy and ADT is better than ADT alone. That is very easily documented literature is there. But what we don't know about radiotherapy is that what is actually the total dose where you will stop and say, now it is enough, this is the point at which the treatment is done. For example, once we do the radical prostatectomy, we are through. There is no further treatment, surgical treatment which can be offered, but I think radiotherapy is still building on further and further, trying to calculate which is the adequate dose. Which technique? There is a lot of debate about conventional radiotherapy, 3D conformal, IMRT, IGRT, which technique is best. And I think at best the evidence is weak that one technology is better than the other, and I will mention that in the literature also. Then how long to take ADT? I think 3 years is a very, very arbitrary figure. It has come down to 2 years. Now it is even 18 months is enough. Now some people are giving 4 months also and ADT followed by this thing. So it is not at all, the boundaries of radiotherapy are still developing as far as I'm concerned. Whether pelvic radiotherapy should be given and in which cases it should be given, and how does the radiotherapy and ADT stand versus surgery and post-op radiotherapy and ADT. Similarly, even surgery has some unanswered questions in T3 and locally advanced disease. Although it has good results vis-a-vis cancer control is concerned, and 60% cancer specific survival at 15 years is mentioned in many studies. But most of these studies are in the pre-MRI era is there, and MRI has changed the way we have approached prostate cancer over the last few years. It has become very, very important in the diagnostic build-up to prostate, to the treatment agenda, which we will start. And as Aditya had mentioned in the morning, now you're thinking about doing away with the biopsy only just because you have a very good MRI specificity. However, when you are diagnosing T3 disease, MRI is not as sensitive as we sometimes think it to be. So it has a 99% sensitivity in detecting prostate cancer, but if you look at T3 disease, it falls far below 50% to diagnose which patient is T3 and which patient is T2. The diagnostic ratio is very, very low. So, my dear Dr. Kannan, those patients which you are taking up for T3 might actually turn out to be only T2 disease, and this actually makes a point that you are over-treating some of the patients. So almost 30% of the patients which were pre-operatively diagnosed to be T3 on MRI will ultimately downstage to T2 disease and will not need any further treatment if they undergo a surgical treatment. So the current issues vis-a-vis radiotherapy and surgery in T3 disease are that imaging guided staging is not accurate. Why? You can diagnose that there is a prostate cancer, and you can probably make a wild guess whether it is T2 or T3, but like I showed you the literature, it's not very convincing, and it is not collating with the final surgical results. We also know monotherapy is not effective. So if you are giving radiotherapy alone, वैसे तो चुपके चुपके आप ADT भी ऐड कर देते हो बीच में, which actually makes it a multimodal therapy. But if you are doing radiotherapy alone or surgery alone, it is not probably sufficient for a treatment protocol. Currently, because of the developing prowess of the surgeons, look at this conference itself. 2 radical prostatectomies performed yesterday. In the whole of my 3 years in All India Institute of Medical Sciences, we have done 3 radical prostatectomies. In one day, we have done 2 over here. The surgeons are becoming more aggressive, and they are more likely to offer surgery due to increase in their surgical prowess. And one of the most common problems which patients face in my practice is that the radiotherapy is a protracted affair. You have to be there for 2 months. Over a long period of time, you are expected to stay near or nearby the hospital, and becomes a big problem for outstation patients. There are certain advantages which radical prostatectomy has. There is a decrease in tumor burden. There is an accurate and precise staging which may avoid RT radiotherapy altogether. So if you have a T3 disease, it was misdiagnosed, and then post-operatively you find that the margins are negative and it's a T2 disease, so you can skip any radiotherapy or any ADT in these cases. But you can also identify patients at high risk of recurrence and make a personalized treatment protocol for this. The cancer-specific survival is maximized following surgery, radical prostatectomy. Recently, studies have come up, and even the guidelines are beginning to sort of mention this fact in their papers that CSS is actually maximized following surgery. I'm not talking about the overall survival. And of course, when you are talking about any kind of rescue therapy, it is radical prostatectomy before radiotherapy is a different ballgame as compared to radical prostatectomy after radiotherapy. So having said that, I don't think either of the two modalities, whether radiotherapy or radical prostatectomy, are actually equal to the task of completely treating a T3 disease. So you have to have adjuvant therapies, and of course you have these 4 adjuvant therapies over here. You have the radiotherapy, the adjuvant and the salvage, the hormonal therapy, chemotherapy, and the combinations of these which you might make of your choice. Just to refresh ourselves, adjuvant therapy is immediately post-op irradiation in case of extracapsular invasion positive, which are basically T3 disease. The recommendations are you can start adjuvant therapy immediately. And salvage is when you wait and see after the surgery and the tumor bed irradiation is done in case there is a PSA relapse or a BCR is there. So I don't think I can argue with you that radiotherapy actually enhances the effect of radical prostatectomy after the surgery. Yes, once radical prostatectomy has been done, the adjuvant radiotherapy actually increases the CSS as well as the overall survival, and there is a significantly better 10-year biochemical progression-free survival. Although there is no overall survival benefit, but it is also associated with worse functional outcomes. Therefore, the concept comes up whether to do salvage radiotherapy rather than upfront radiotherapy. And for this, there is this excellent trial of radicals RT. I think as a radiotherapist, you are much more familiar with that. It has not shown any benefit with adjuvant radiotherapy, which is not there with salvage radiotherapy. And observation with salvage treatment for PSA and biochemical progression should be the current standard of care after radical prostatectomy, is the recommendation of Christopher Parker. So if I summate the adjuvant therapies following radical prostatectomy, EBRT, of course, yes, has to be there, especially the salvage radiotherapy. Regarding hormone therapy following a radical prostatectomy and adding on to EBRT, there is insufficient evidence which suggests that hormonal therapy is important, although I think as clinicians, most of us do combine hormonal therapy with EBRT and surgery in radical prostatectomy in T3 disease. And chemotherapy and ADT plus chemotherapy have not yet proven their value. So you see this confusion is there regarding how to treat T3 disease and how to combine the various modalities, and I think it is reflected in the guidelines itself. If you start reading the guidelines, the EAU guidelines as of 2023, the RP can prolong, radical prostatectomy could prolong the survival time of patients with high-risk prostate cancer. However, RT could delay disease progression, and combined radiotherapy and brachytherapy boost even brought a preferable cancer-specific survival, but there was no change in the OS as compared to radical prostatectomy. And EAU guidelines clearly mention that in the absence of high-level evidence, a recent systematic review could not define the most optimal treatment option. So, in my opinion, radiotherapy remains, radical prostatectomy and radiotherapy remains equal, if not better than this thing. Now, considering the weight of the evidence which we have behind making this statement, that we should offer a radical prostatectomy in T3 disease, the evidence is weak. But so is whether we should offer IMRT, VMAT, IGRT, or all these things. The evidence level is very weak as per the EAU guidelines. Whether we should do pelvic nodal or systemic therapy in both these, when we are using both these modalities, that evidence is very, very strong that some kind of systemic therapy is needed for maintaining this patient. So in this context, I want to mention this one meta-analysis the role of radical prostatectomy and radiotherapy in the treatment of locally advanced prostate cancer. The diversity and the inconclusive nature of the literature, it is very clearly seen in this particular study. You see, when they started off with 3,745 articles, but when they narrowed down the conditions, they could only find 14 studies which could actually fit into the protocol. And from that, they could take out a couple of observations. The disease-specific survival was significantly in favor of inclusion of radical prostatectomy in the treatment protocol. So if you did a radical prostatectomy, the disease-specific survival was better, but the overall survival was not much different, as you can see in these curves. And adjuvant RT significantly improved disease-specific survival in those patients who underwent radical prostatectomy. Mind you, this is not a comparison between radical prostatectomy followed by radiotherapy versus primary radiotherapy and ADT, but it says the role of radical prostatectomy is there when you are planning a treatment for a T3 disease, multimodal treatment is there. So here is a proposed protocol for surgical management of T3 disease, and I think this is what most of the clinicians will do in current day and age. At least this is what I do. Before surgery, do not do an ADT so that you get an accurate staging. There are trials ongoing whether an ADT helps both in radiotherapy as well as in surgery. There are trials going on and they are inconclusive. In fact, in radiotherapy, they are little bit averse to giving neoadjuvant radiotherapy because it goes against the principle that radiotherapy attacks fast dividing cells, and by giving ADT, you are actually converting the fast dividing cells into slow dividing cells. Therefore, the role of neoadjuvant ADT in radiotherapy is questionable in this thing. Pre-op MRI is of course a must. When you are doing a radical prostatectomy, tailored local approaches like neurosafe frozen section to ensure that you have negative margins is very, very important so that you can take out the complete tumor at the end of the surgery. And of course, the extent of the PLND, whether to do a extended PLND or a super extended PLND or a simple sampling and is very important. And at T3 disease, you should try and do an extended EPLND at least. And after surgery, yes sir, just coming to the slide. After surgery, the tailored use of post radical prostatectomy radiotherapy is important. You see, in almost 30% of the patients, you can avoid radiotherapy altogether because it has downstaged from T3 to T2, and there will be another group of patients in which you will be able to avoid radiotherapy because the PSA never rose in the later phase. So the conclusion is that radiotherapy-based multimodal therapy is in a developing stage and looks, radical prostatectomy-based multimodal therapy is in developing stage and looks promising. The RP-based multimodal therapy is a sequential series of steps that allows personalized medicine. That is the difference which can be there. The main advantage is in avoiding radiotherapy and hormonal therapy protocol altogether in almost 30% of the cases, if not more than that. And another advantage is in those cases who are margin positive and who still require salvage radiotherapy, the radiotherapy is delayed significantly, which can delay the onset of long-term complications of radiotherapy and gives you a better QOL down the line. So one of these questions are going to be probably resolved with the SPCG 15A trial, which is going on currently. The target is to enroll 1,200 patients, and as of the last information, they have enrolled about 800 patients, and maybe we will see some answers to these the questions which are arising over the next few years. So the basis of multimodality therapy is that radical prostatectomy offers better OS and CSS over longer durations. It offers possibility of minimal medication after surgery. The complications of radical prostatectomy are less than IMRT over the long run. Therefore, there is an effort that you should avoid radiotherapy, and that goal is set. And it is not possible to do salvage surgery after radiotherapy. Therefore, if radical prostatectomy benefit has to be taken, it has to be taken before you offer radiotherapy to the patient. Thank you very much.
I think that's very well debated, good points, only that you took double the time, so you would probably be double more impressive than the other one. But taking cue from, other similar malignancy, which is breast malignancy, the thing have revolved around and multimodality has come to stay there. I am very sure that even for this disease, multimodality could be the way forward. But as you say that, study is just on, and it will take another 10 years at least before we have the results. Thank you.
Thank you very much.
Thank you, sir, for fantastic talk. If there are any further comments from chairperson, sir, Sabni, sir, and yes, sir. Sure, sir. Yes, sir.
Localized prostate cancer, and one does a radical prostatectomy and there is a lymph node positive, otherwise all margins negative. Now the PSA in follow-up, neither PSA is 0.01. What is the recommendation for further treatment in form of radiotherapy in such patients?
The node positive disease traditionally has been an indication to add adjuvant treatment, which is adjuvant treatment. But if the lymph nodes are less than 2, there is enough literature to suggest that you can wait for the PSA failure and treat it. There are studies where the lymph nodes become positive after the study on PSMA, and lymphadenectomy have not yielded any results.
Yes.
So I think node positive disease in prostate cancer remains more of a sampling than curative against, unlike urothelial cancer. And a node positive disease is considered a metastatic disease practically, unless it's limited to less than 2 and when the periphery of the lymph node is not involved on histology.
So the same thing gets reflected onto the locally advanced cancer, like Swapan very well presented. So the best answer is biochemical follow-up of these patients. In case you have got good PSA control, they may not even require radiotherapy rather than subjecting them to radiotherapy.
Which is true, which is what they have said.
Can I just add one small point?
The philosophy has changed with the advent of PSMA PET. You detect the biochemical, the motto remains how long you can delay ADT. If there's some evidence, then go for treatment. If not, yes, you can wait and watch. Yes, that's right.
But lymph node positive and the locally margin positive or extracapsular extension, they are totally different. Lymph node is far off, and if it is positive, then it has to be considered as a significant disease. Whereas even if there is some extra capsular extension or some margin positive, local little bit margin positive, still what you said is all right, that you monitor with PSA and then subsequently give the adjuvant radiation later on as a salvage, but not appropriate when the lymph node is positive.
Yeah, and when you are following up these patients, then you have to check the PSA doubling time also. If the PSA doubling time is short, less than 6 months, then these patients are appropriate candidates for ADT rather than for radiotherapy, rather than for salvage radiotherapy.
Excuse me.
Dr. Gopal.
Thank you very much, sir, for this.
Sir, I would like to add a point regarding radiotherapy, this salvage. So this, if you look at the cases, the trials of salvage radiotherapy, they are have all taken cases of localized prostate cancer. It's not locally advanced. So it's localized prostate cancer, which they have incidentally found to have pathologically T3A or T3B. Even if you see the radical sati trial, nearly 90% of the patients had pathologically T3A, whereas even T3B is just less than 10%. So we don't have adequate evidence to recommend salvage radiotherapy in a locally advanced case, upfront locally advanced case. So I don't think doing salvage in a case of T3B where you operate and then keeping under follow-up and then keeping for salvage radiotherapy. As of now, we don't have evidence, level 1 evidence to say for that.
Right, sir. Thank you very much, sir. And I think it remains one of the gray areas in our field until unless the trials, SPCG 15 trials results are available. So I would now move on and request Dr. Siddharth Yadav, who is Associate Professor from VMMC and Safdarjung Hospital, to give his talk on current status of neoadjuvant therapy in prostate cancer. Over to you, sir.
So, yes, sir. So, good morning, respected chairpersons, teachers, and my dear friends. I'll be speaking on the current status of neoadjuvant hormonal therapy in prostate cancer. So, neoadjuvant therapy has played a significant role in a variety of cancers to improve the cancer-specific survival. It works primarily by local downstaging, thus reducing the chances of residual local disease, and by managing the distant micrometastasis at an early stage. So around 26% of the patients who present with localized cancer prostate have high-risk disease, and despite local treatment, these patients have poor outcomes with a 10-year biochemical relapse rate of around 50% and a 15-year cancer-specific mortality of 19%. Neoadjuvant hormone therapy can actually, by local downstaging and by providing early treatment to metastasis, can possibly improve the biochemical BCR rates and improve the overall survival. The therapy can be delivered either by neoadjuvant hormone therapy, which has already established itself in patients who receive radiotherapy, or can be done by neoadjuvant chemotherapy or by immunotherapy. In this talk, we will be discussing the role of neoadjuvant hormone therapy prior to radical prostate. So there is a large body of data evaluating the role of conventional ADT in patients who are undergoing radical prostatectomy for possibly high-risk prostate cancer. And these have all concluded that although the pathological response are good, with a 50% lower chance of positive surgical margins, 40% lower chances of positive lymph nodes, and 60% higher chances of organ confinement, PTT0 is seldom achieved. And the oncological outcomes tend to remain same. They do not improve. And even if the conventional ADT is given for a longer duration, that is 6 months as compared to 3 months, there is possibly no effect on the long-term oncological outcomes. So to summarize, the conventional adjuvant therapy, although it improves the local control, there is no benefit in survival. It is commonly believed that the conventional ADT does not reduce the intratumoral testosterone to a significantly low level, and its lethal potential is actually doubted. With the advent of novel anti-androgens, such as abiraterone or second-generation androgen receptor blockers, which have the potential to reduce the intratumoral testosterone, there is a resurgence in interest in the neoadjuvant ADT prior to radical prostate. So the two phase 2 trials have evaluated novel anti-androgen monotherapy in patients undergoing radical prostatectomy. The first trial evaluated apalutamide for a period of 3 months and found the results that no patient had a pathologically complete response. And second trial evaluated enzalutamide and showed similar poor results. So novel anti-androgens seldom achieve pathologically complete response, and their oncological efficacy was deemed unlikely. So there was a need for a stronger ADT. And a combination of novel anti-androgens with the conventional ADT was found to have a higher reduction in the intratumoral testosterone levels. So 3 phase 2 trials have evaluated the combination of novel anti-androgens with the conventional ADT and found that the combination is superior to ADT alone as far as the pathological outcomes are concerned. The pathologically complete response rates are much higher, a large number of patients have minimal residual disease, and the PSM, node positivity, and T3 disease are much lower. So the pathological outcomes are good. However, the lower pathological complete response rates and high PT3 rates suggested that a more effective androgen deprivation could be tried. And a dual novel anti-androgen with conventional ADT in a form of triplet has also been tested, with an aim to block the androgen production in testis, adrenal, as well as the tumor, and having a maximum androgen receptor blockade. But 3 phase 3 trials have evaluated this concept and found that the triplet is almost equal to doublet as far as the pathological responses are concerned. All these trials are actually phase 2 and have not reported the clinical outcomes. So in absence of phase 3 trials, the Dana-Farber Cancer Institute assessed the clinical outcomes of patients who were enrolled in phase 2 trials at their center. They end up including 63% of all those patients who were enrolled in their trial. 80% of them had high-risk disease, and 44% had Gleason score of 9 to 10. They found out that the pathological responses were good, similar to what was reported in the phase 2 trials, and the oncological follow-up, at a follow-up of 3.6 years, the biochemical free rate was 59%, and the metastatic free rate was 87%. The patients who had a good response or an exceptional response to hormone therapy did favorably well as compared to those who did not have the response.
They also suggested that certain markers on biopsy, such as the loss of P10, loss of P53, and positive ERG, could predict poor response to hormone therapy, and these patients can be avoided neoadjuvant hormone therapy. The only comparative study comparing the clinical outcomes of neo-hormone therapy versus RP alone compared the patients included in phase 2 trials with the previous cohorts of high-risk prostate cancer. They found that the pathological outcomes were obviously very good, but the oncological outcomes were superior in patients who received neoadjuvant hormone therapy. The 3-year freedom from BCR was much higher, and 3-year metastatic free rate was much higher in patients who had received neoadjuvant hormone therapy. 93% of the patients who receive hormone therapy will have testosterone recovery at a median period of 4 months, and the sexual functions tend to be similar at the level of 6 to 12 months. The adverse events also fall in line for those what is reported for metastatic cancer prostate, with triplets having slightly higher adverse events as compared to the conventional ADT. Now, as far as the complications and the perioperative outcomes are concerned, they remain same whether the patients have received hormone therapy or they have advised a radical prostatectomy upfront. The only complication, that is the thromboembolic events, are slightly higher in patients who are giving ADT. And some groups have also evaluated the feasibility of nerve preservation and have suggested that reduction in the tumor volume allows for greater nerve preservation and maintenance of the sexual function in the postoperative period. Now, to better establish the role of neoadjuvant hormone therapy, a couple of trials are on way, and we are still awaiting their outcomes. So, as for the guidelines are concerned, currently they do not recommend to offer neoadjuvant deprivation therapy before surgery because of lack of overall survival in patients who have received conventional ADT, and because of lack of phase 3 trial data for patients who are going to receive or receiving neoadjuvant novel therapies. So, to conclude, the conventional ADT did not show any overall survival benefit when administered prior to radical prostatectomy. The neoadjuvant ADT with novel hormonal agents, the role is still evolving. There are phase 2 trials, no phase 3 trials are available. Doublet and triplet combinations have been tried and have shown some oncological benefit. 20% patients may have exceptional responses, and genetic alterations can help in selecting out patients, those who are going to respond to hormone therapy. Thank you.
I think very good, very well summarized. And I think if there are any question from the floor, we can take up. But again, I think going by the logic of and going by what happens usually with other tumors, I think with high-risk patients, again, we would prove in the end that neoadjuvant treatment may be effective in these patients.
Just to make a comment,
Sir.
we have been practicing in locally advanced tumor to give hormone at least for 3 months minimum and doing the surgery, and we are about to publish it. The result is that you can make some of the non-operable tumor to operable and cut down their positive margin and complication rate, and sometimes which was looking not possible to lift from the rectum, you can avoid all those injuries and make it possible to do that.
Sir.
And all these patients invariably require salvage radiotherapy very soon.
Sir. Thank you, sir.
Thank you very much, sir, and it was a very well summarized talk. Now, I would request Professor S.K. Singh to keep on sitting for the next session as well. I would also request Professor N.P. Gupta to co-chair this session. Thank you. So, now we have a debate, and it is one of the hot topic right now, I would say. And is it time to stop the ticking clock? And for yes, first would be speaking Professor Anand Kumar, who is chairman. I think he doesn't need any introduction, but he is chairman from Max Saket, Department of Urology and Robotic Surgery. Thank you very much, sir.
Respected teachers, dear friends and colleagues, at the beginning I will say stop the clock. Now today I am debating against an established practice and against a legend, my senior and good friends, and I am for the notion challenging sometimes that is in practice for last 30 years. How many of you will unclamp at 30 minutes no matter what stage of surgery you are, and you will like to compromise oncological outcome? Answer is nobody. In partial nephrectomy, yes, we need avascular control for the deep parenchymal tumor, endophytic tumor, hilar tumors, for better enucleation or enucleoresection, good hemostasis and good oncological outcome. Just to show a very short clip, you can see this tumor which is sitting exactly in the hilum around the vessels. And if you are doing such kind of tumor, you will take more time. And you can see the tumor is projecting into the hilum and all the vessels are around it. So if you are going for it, so like in this case we did the cortical, which I called cortical episiotomy, and you can enucleate the tumor because you have to be careful not to injure the hilar vessels because you want to have the good blood supply to the rest of the kidney. So you have to separate it very carefully with the surrounding vessels and enucleate the tumor. Then you'll have to repair the pelvic lethal system, and we always declamp, and if there is a vascular injury, that we take care of at the same time. And then there is a defect which you want to close it without causing compression to the hilar vessels. So you have to loosely put the flow seal and Surgicel and do close approximation. So if you are doing all these things, you are going to take more time than what is currently set 25 minutes. But like this patient has come for follow-up, is doing very well, negative pars emerging, and DTP is showing good function. But from where this has come, that 25 or 30 minutes is the deadline. So this came from great surgeon, Dr. Andy Novik's paper, and he quoted a study done in 1974 on canine model. And you know that all the animals' kidney tolerate differently. Mice kidney can tolerate 20 minutes, canine kidney can 30 minutes, and the pig kidney can tolerate up to 90 minutes. And human kidney is more complex than any one of them, so same can't be applied to us. There are many papers, and when these papers were initially published and multivariate analysis was done, it showed significant association between warm ischemia time and post-operative renal outcome. But on univariate analysis, all have said only significant association between preoperative GFR and renal parenchyma preserved. So the concept mainly started the publication which came in 2010, in which they collected data from Cleveland Clinic and Mayo Clinic for all the patients who had a single kidney and warm ischemic resection. And then they said that, and they analyzed every 5 minutes and with the GFR, and they said after 25 minutes, every minute counts. So but that was retrospective studies, and there were many flaws in that. And when they reanalyzed the study after a lot of criticism, 2 years later, they published again, and then they said that warm ischemia time is a continuous variable, was no longer an independent predictor of renal function. Quality and quantity of the remaining parenchyma is determining factor, and they concluded every minute does not count. And I recently reviewed a very good paper in Journal of Endourology where this animal experiments, and they clamped the single kidney model for 90 minutes, and all the pig kidneys recovered. So kidneys of different species are very complex. So it is time to stop clicking the clock, and this is the very nice paper published by our friends Deep and Parekh. And what they did, that it was all open partial nephrectomy. They did kidney biopsy before, during operation, and after that, and deep biopsy including the medulla. And they did electron microscopy and a lot of biochemical studies. They did show that there was some mitochondrial swelling, structural changes which were mild, which slowly recovered. And they took 15 minutes to 61 minutes. And in that paper, they emphasized that human kidney has got a lot of tolerance and that 30 minutes time is no more valid. And then from 2019, many papers started appearing and showing that this is the time to stop the clock clicking. And it is the editorial written by Deepan Parekh. And finally, he said we have to concentrate more how the good quality parenchyma have while when you are going to do it, and how you can optimize, like if you can optimize diabetes, hypertension and fluid before doing all that, that is better than looking at the clock. And this is the one of the best paper have appeared last year in European Urology, in which they try to look in 25 centers in China and Cleveland Clinic for all those patients who had a partial nephrectomy, and after 6 months to 2 years, 2.5 years, and again radical nephrectomy, and they took the tissue from the away from the tumor in the radical nephrectomy specimen and the partial nephrectomy specimen to see what happened in follow-up when the kidney was removed. What the kidney damaged in that 2 years period time or not. And this was very good study in which they have shown like this, the upper one, which was the parenchyma was normal, nothing happened in 2 years follow-up. The parenchyma which was diseased, had peritubular fibrosis, glomerular changes, vascular changes, has progressed to the chronic renal failure. So the conclusion was, if the kidney was not of good quality, it will develop renal failure after the partial nephrectomy. If the kidney is good quality, ischemia, it will tolerate the ischemia time, and in that study ischemia time did not make any difference, and they have collected 147 cases, but only 63 cases they could analyze, which has all the possible information available. And this is another clock trial. Clock means clamp on and clamp off, done in Italy. And there actually in this average time was in both the series around 16-17 minutes, not much. And they basically concentrated 6 month overall GFR deterioration or change in GFR. And they found that there was no change in GFR at 6 months, 18 months and 2 years. So again, that shows that ischemia time does not matter. And this is the meta-analysis which has come up, including all the papers showing that whether off-clamp or on-clamp matters or not. And again, it has said that it is the quality of renal parenchyma before the partial nephrectomy and how much parenchyma you have saved make the difference, not the ischemia time. And if you look at, this is very important here, the pre-op GFR, pre-op hypertension, diabetes, cigarette smoking, cardiovascular disease, age of the patient. So that shows the quality of parenchyma. And when you do partial nephrectomy and how much parenchyma you have preserved in resection and how much parenchyma you have, like I have seen people take a lot of cortical stitches. We don't do cortical stitching, we just do the internal renography. How much parenchyma got finally destroyed will lead to the recovery of the kidney rather than the ischemia time. So if you worry too much about ischemia time, you try to cool the kidney while doing open or the minimally invasive procedure. That will help us in preserving the kidney. And this is the technique which we perform, like from very beginning, early declamping and segmental clamping. That way you can preserve the rest of the kidney from any ischemia. And this is the editorial appeared in last year in European Urology, and very well written editorial, and it summarizes, and it has heading also. This is the time to stop the tick-tock dance. And it said, growing body of literature suggests that duration and type of ischemia far less influence on post-operative renal function than classical dogma has led us to believe. So I would like to some of my experience, like many times in laparoscopic partial nephrectomy, we have taken more than 45 to 55 minutes. And I have spoken to many good friends, including the great surgeon Inder Birgil, who has also confided that in complex cases he has taken 50 minutes, 55 minutes, but all those kidneys have recovered. In my early robotic transplant, we have taken 60 minutes, and we saw that ice melts within 10 minutes, but kidney recovers. In open transplant, we have, in multiple vessels, we have taken 50-55 minutes, but all those kidneys start making urine and recovers, and these are the single kidney model. And some of the patient in transplant, we did post-op, urine is not coming, did ultrasound, and there was some problem. There is vascular compromise, and we opened the patient 2 hours, 3 hours, 4 years, one renal thrombosis we opened after 7 hours, years something. And all those kidneys recovered. So that kidney, human kidney has lot of resilience. So I would like to conclude that I don't say the warm ischemia time is not important, don't take more than 1 hour and all that. But the 25 minutes, 30 minutes is not all that you should worry about it. I know this statement will be music to ears of many of our colleagues, because that will take away their stress doing this operation. The aim is to give good complete oncological clearance and good hemostasis, so take few extra minutes to prevent re-exploration and get good negative positive margins. So if you are looking at the watch, which my friend will be sweating and sweats will be dropping over the patients, but if you don't look at the clock, clock is not matter, you will be happy surgeon, happy fellow, happy patient, and Dr. Alawat will also be happy if he is not looking at the clock. Thank you.
Thank you, Anand, for excellent review of the literature and your personal experience that we should stop towards the clock. And may I request Dr. Rajesh Alawat to say that no, we should look towards the clock when we are doing partial nephrectomy. And I think so every surgeon is putting on that clock when they are doing partial nephrectomy. Have you stopped, Anand Kumar, that?
He has stopped even in transplants. Now he goes for lunch, comes back and then puts the kidney in. You should start doing that. If the clock has to stop it completely. Moreover, when you say that these kidneys recover after 40 minutes and 45 minutes and you took 1 hour for transplant, yeah, that's cold ischemia. The tolerance limit is much more. Well, anyway, he has already beautifully put both the points in front of you, or you all. And let's go on from here. Okay. So, what is the basis? What is the need for nephron sparing surgery? So it's recommended for all T1 lesions. We need better functional outcome. That's the basis. Why do you need? Because it's better than doing a nephrectomy. Even those small saved nephrons would save the patients from chronic kidney disease and the cardiovascular morbidity and mortality that these patients are going to have because of the CKD. And it would be important. It would be important when you have a baseline CKD, when you have comorbidities, and when you have solitary kidneys. So that would be the population where you need it the most. And fortunately or unfortunately, in all these randomized studies that they have quoted, these cases have been excluded. So we'll come to that later on. So predicting renal function loss post-operatively following partial nephrectomy, how would you give a good function post-operatively? It depends on 3 Qs, which is what is the quality of the kidney you are handling, what is the quantity of tissue that you are leaving behind, and how quickly you do it under ischemia. And this is the same diagram that Dr. Anand showed. From a journal, when you say that you have, so do we have a pointer here? Well, anyway, so go back. Can we go back on this? Yeah. So it's the same thing that as far as the quality of parenchyma is concerned, no, there is none. Yeah. So there is when you talk of quality of parenchyma, you have no control. So everybody, you are given by the patient the quality of parenchyma that he comes with comorbidities, diabetes, hypertension, nephropathy, single kidney, whatever it is, you can't change that. But when you come to quantity, yes, there are factors like tumor complexity and tumor size. The one which are surrounded by the green are the factors, again, you cannot change. But what you can do is that, drugs that you are using, excisional volume, the amount of devascularization that you have done, that you can change, and that is what will matter. As far as ischemia, even in ischemia, there are so many factors. You know, fluid management, whether you have primed the patient with the drugs which will save them, save the parenchyma from ischemia, ischemia time, whether it is cold ischemia, warm ischemia, and ischemic techniques, you know, segmental, otherwise. So there will be so many variables there. And when you start talking of only warm ischemia as a variable, everything gets diluted. So histologically, you know, you give ischemia and ATN or tubular tissue is the most vulnerable one. But once you consume the basic battery of ATPs by converting them to monophosphates, the tissue edema starts occurring, the cell wall integrity goes away, and you have cell death. And then once you revascularize, there is a thrombus, and then there is a cortical necrosis, which is a natural sequencing of events once you institute the ischemia. So the clock tick matters. You know, histologically safe duration of warm ischemia time where full recovery of renal function is expected has been 30 minutes. It's very arbitrary. It's a continuous variable. You cannot cut it anywhere. You know, 30 minutes, 40 minutes, for 20 minutes. There is no cutoff. It's a continuous variable. And we continue, that's why we continue to push the narrative toward minimize the warm ischemia, and correctly so. The origin of this debate is these two things, you know, those two things that Dr. Anant Kumar has shown you, that porcine studies which tolerate 90 minutes, but is human kidney a porcine kidney? No. And some level 1 trials which have, you know, one of the trials was this, which is Thompson-Anderson's trial, in which single center, 40 patients in each arm, off clamp and on clamp, 19 minutes versus 0 minutes. So now mind it, this is the thing that you have to keep in mind. This experienced surgeon, more than 400 partial nephrectomies done, single center, single surgeon, 19 minutes versus 0 minutes, and says that there were similar perioperative outcomes. Clock trial that Dr. Anant Kumar has referred to, robotic 160 versus 164, there were 14% conversion from on clamp to off clamp. There were 43% conversions from off clamp to on clamp. And then warm ischemia was 14 minutes and 15 minutes, and there was no difference. So obviously there would be no difference. Clock 2 trial, which is the laparoscopic trial, 123 versus 126 patients. No differences were found in the outcome, but impressive. So Dr. Anand says we should stop the TikTok dance, we should go for lunch after retrieving the kidney, and we'll put it after once the lunch is over. So why are these null results? No, ischemia time is just one of many factors we have shown. It's a continuous variable. You cannot cut it at 20, 30, or 40. Impact of ischemia time, which is less than 20 minutes in most of these trials, when within reasonable limits, may get diluted with what other factors are: comorbidities, tissues, parenchymal suturing, parenchymal loss by the patients, by the surgeon, his experience, so everything counts. An inclusion criteria of normal preoperative renal function, bilateral kidneys, and solitary renal tumors. So in that population, obviously, the impact would be the least. So ischemia and partial nephrectomy in solitary kidneys, these are the studies that we have to see whether there is impact or not. And in this multi-institutional trial, off clamp 85, warm ischemia 174, cold ischemia 278, and in warm ischemia of more than 20 minutes and cold ischemia of more than 35 minutes were associated with a higher incidence of acute renal failure requiring dialysis postoperatively. Warm ischemia of more than 20 minutes was associated with an increased risk of chronic kidney disease, 41% versus 19%. An increase in creatinine of more than 0.5, 42% versus 15%. So this is the real population where ischemia would be the most important, and you cannot stop the clock here. So this is data from the clock trial itself, which everybody says that it's a level 1 trial. And in this trial, what they have done is they have done DTPA preoperative, they have done DTPA postoperative, and these are the 3 parameters of the GFR. If you absolute variation of eGFR at 6 months, rate of relative variation in GFR more than 25%, and absolute variation in the split renal function of the operative kidney at scintigraphy at 6 months. And you see that there is a 5-minute line, 10 minutes line, and 15, 20, and 25 minutes. If you start seeing after 10 minutes, there is a decline and change in every parameter. And it was concluded from the clock trial data itself that up to 10 minutes of warm ischemia had no consequence on functional outcome. Above the 10 minutes threshold, a statistically significant but clinically negligible impact was found. So humans are no porcine. We cannot rely on the data that 90 minutes of ischemia is good for the humans also. So if one could stop the clicking talk, he would go for lunch after removing the kidney. And it's time to stop the clicking talk, please, no. Always keep the time on your side and always mind the amount of ischemia that you give to the kidney. Thank you very much.
Thank you, Rajesh. And the clock is ticking there, you see. So both are senior, experienced partial nephrectomy and renal transplant surgeons, and both have highlighted very nicely starting from the literature. I have also read of those articles and the new one, but certainly warm ischemia time has to be less, as much less as possible, without compromising the quality of surgery, the principles of surgery and all that. I think so clock has to tick, but ask your anesthetist to click the talk. You don't look towards that. And at the end, you just ask him how many minutes. That is for record purpose. I think so. Anyone like to make any other comment? But I think so they have highlighted the points very well. Thank you, both of you.
Thank you, sir.
Thank you very much, sir. I think this was the debate which I was most looking forward to, and I think it has lived up to its billing. So now I will move on to next talks. Now we have case-based discussions or discussion for management of small renal masses that is less than 3 centimeter. And first would be Professor Ravi Mohan would be speaking for active surveillance. Over to you, sir.
Thank you, Gopal and North Zone and ISU for this opportunity. So my only role here would be to impress upon that when we should do active surveillance, how we should do it, what are the signs when we should not do active surveillance. Because I also personally believe that whenever possible, we should try to remove the kidney. But let's see, there are situations where we need to do it. I have nothing to disclose. So active surveillance is a self-explanatory term that you observe a specific tumor till it becomes problematic. It's almost similar to as in prostate cancer done for small renal masses. So there are patient factors and tumor factors which would govern active surveillance. Now in patient factors, here where it differs from prostate cancer, where in prostate we say that active surveillance should be done in patients where the expectancy is beyond 10 years. Here in kidney, it is not well defined. So when the harms of treatment are more than the benefits with respect to the outcomes, active surveillance is what is considered in kidney tumor management. So elderly patients with life expectancy less than 5 years, multiple comorbidities, excessive perioperative risk factors, frail patients, and marginal renal function. These are situations where one should consider active surveillance. Then in tumor factors, when the tumor is obviously smaller than 3 centimeters or the growth rate is less than 5 millimeter per year, non-infiltrative tumors, low complex tumors, favorable histology. We'll discuss as we go along with it for the tumor factors. These are the things which favor active surveillance. Now, what is the rationale? It is not like patients would come and when the moment they see a renal mass, they would say, "Doc Saab, just nikal do," and they're so much afraid. But actually, SRMs, the small renal masses, are known to grow very slowly. The average growth rate reported is between 0.1 to 0.34 centimeters per year. And majority of the patients, even when they need delayed intervention, would actually we will be able to do a partial even in that situation. So that's the reason, and less than 1% actually metastasize. So that's the reason why we can offer active surveillance for small renal masses. How to do active surveillance? Again, this flowchart is very simple. Do CT scans every 6 monthly for first 2 to 3 years. Then subsequently annually up to 5 years. If the disease is stable, discontinue it, because then you know that beyond 5 years it's less likely to grow unless the tumor biology changes, which happens by chance. If it's a slow growing, continue the annual follow-up. and if there is progression and what are the pointers we'll discuss, and then go through a multidisciplinary team and discuss about the treatment. Now, what are the triggers of progression? And there are various societies which have defined triggers of progression, and primarily it is the size of the tumor which is a major determinant, and the tumor growth rate. So, according to a consortium from Canada, Renal Cancer Consortium from Canada, they say that SRM should be done for tumors which are beyond the active surveillance should be stopped when the SRM grows beyond 4 centimeters, or the doubling time is less than 12 months, or metastasis. This SRM group says again that when the growth rate is beyond more than 0.5 centimeters per year, one should discontinue active surveillance, or the presence of hematuria, or the size more than 4 centimeters. ASCO and AUA, again, AUA differs a little, that it says if the size is more than 3 centimeters, we should stop active surveillance, or presence of metastasis, or there is a progression from to T1, increase in T1A. Now, there are special scenarios. Suppose you have a multifocal tumors, what to do, or some hereditary tumors, should we really do active surveillance or not? So, in multifocal tumors, it is recommended to do a renal biopsy, not in a unifocal like I had a patient yesterday. The multifocal tumor, one should do biopsy and focus on the tumor which is more than 2 centimeters in size and see the growth kinetics, and based on the criteria as we discussed, one can decide for treatment. And for hereditary tumors, the common hereditary ones, von Hippel-Lindau, hereditary papillary RCC, Brit-Hogg-Dubé, and tuberous sclerosis, these are the ones where you can actually do active surveillance. These are the major or most commonly seen multifocal tumors. Here one can do active surveillance up to 3 centimeters. And whenever you have a tumor which is beyond 3 centimeters and you are operating, try to remove all of the tumors which are even less than 3 centimeters, because you won't get a chance to go in again and again in that region. So the philosophy is that you remove the bigger one, but also remove the smaller ones if you are intervening. But for tumors like hereditary leiomyomatosis, succinate dehydrogenase, or BRCA1 associated, or MITF predisposed RCC, they are the aggressive ones. Here active surveillance is not recommended. Then when not to do active surveillance, obviously benign masses, there is no need. Renal masses is irregular borders where the tumor doesn't have a good capsule, infiltrative tumors, non-localized tumors, certain hereditary variants as discussed, and obviously when the patient refuses for active surveillance. So dear friends, my take home is active surveillance is definitely an option in SRM. Close and longer follow-up are important. Renal mass biopsy should be done especially for the multifocal diseases. Progression either by size or growth rate should trigger intervention, and certain hereditary SRM should not be allowed on active surveillance, and NSI should be feasible even if even on active surveillance. That's the aim. Thank you.
Dr. Ravi, I like to ask you only one question. Now imaging has improved so well, and the enhancement, how much is the Hounsfield value? Does that matter in deciding which will be the slow growing, which will be the fast growing?
Sir, there is no study which will tell that specifically, but a tumor which is less than 3 centimeters, even if it is a clearly malignant one, can be kept on active surveillance. So that is the literature support on that, but there is no specific criteria to tell the growth rate kinetics with respect to the enhancement.
No,
but if it is less than 3 centimeters.
In your slide of abnormal histology, you mentioned that some tumors which have to be operated. How do you know that without biopsy? So what is the role of biopsy when you are putting a patient on active surveillance?
So in active surveillance, sir, only in patients which are multifocal tumors or there is a syndromic tumors, their biopsy is recommended. Otherwise, not for all any SRM which we commonly see on incidental mass which is less than 3 centimeters, you need not do a biopsy. Let's say a 60-year patient presents with an incidental mass, you did not do a biopsy. But if it's a 20-year male or there's a strong family history where you think that it might have some hereditary component, we do a biopsy, and then if on those biopsy we find specific genetic abnormalities, then we decide whether we should continue with active surveillance or should we remove it.
Thank you.
Thank you.
So actually whether to keep the patient under surveillance or to do intervention, that depends on the tumor factor and the patient factor. Both need to be considered. Thank you, Dr.
Thank you, sir.
Ravi Mohan, thank you very much. Thank you. Yeah, Dr. Gopal, yes.
Thank you very much, sir. Now I would request Dr. Ujjwal Gorsi to give a talk on small renal masses, point for focal therapy. Thank you, sir.
Yes, so when you have to intervene, yes, how to intervene, that need to be decided. In consultation with the patient, you have to tell all modalities of therapy. Yes, minimally invasive modality without, again, making a hole into the abdomen can be done, and then Dr. Gorsi is going to apprise you about that, how to do tumor ablation.
Thank you, sir. So just a brief, what we can offer in the tumor which are less than 4 centimeter as an intervention radiologist. So percutaneous tumor ablation, direct application of energy to destroy tumor. AUA and NCCN see it as a potential curative option for selected patient tumor with T1A. So indications, what are the factors, what are the tumors in which we will think that either active surveillance or surgery, this ablation can be done. So if patient is surgically unfit, where preserving renal function is paramount, like CKD patient, solitary kidney, hereditary condition as sir was just mentioning, poor surgical candidates, but with larger but still localized RCC and recurrence after surgery. So these are the some indications in which the percutaneous tumor ablation can be done. It can also be done as a palliative treatment when advanced stage of RCC to control symptoms such as pain and hematuria. So ablation, there are 5 types, basically RFA and microwave. These are heat-based ablation where you are using thermal ablation to destroy a tumor. IRE is electric, and cryoablation is a cold-based, basically ice-based therapy which is used to done ablation, and HIFU is high-intensity focused ultrasound. So in RCC, most of the data is on RFA and cryoablation. So if you see how does an RF ablation work, so basically alternating current is passed, ionic excitation occurs around the needle tip, heat is generated, and there is a coagulative necrosis. But RFA heating is, it takes a little time, like 10-12 minutes, and there is something known as heat sink effect. If a blood vessel is there very near to ablation, so whatever heat you are generating, that get displaced by that, decimated by that blood vessels which are near, and ablation can take little time. So microwave, usually it takes a electromagnetic energy. So here, it's again heat based, but it happens fast. Like same ablation which for RFA takes around 30 minutes, it can be done in 5 to 6 minutes with microwave ablation, and larger ablation zone can be applied. Cryoablation is little different. So here there is something which is known as Joule-Thomson effect. So there are certain gases. So these gases, when they are traveling under high pressure and they are made to point to a very small, like pinhole kind of thing, so that is the pressure from high pressure to low pressure, they suddenly expands and cools. So this is known as Joule-Thomson effect. Argon and nitrogen are 2 gases, and this, when they cool, the temperature that can be reached is up to minus 150 degree. So at such low temperature, nothing survives, tumor doesn't survive, and ablation happens. So components of cryo, this is what we have in PJ. So this larger one is the helium. Helium is basically thawing agent. So once you have cooled, you have to bring the body temperature to the normal. So there you use helium. For in the typical cryoablation is done as a 30-minute cycle. For 10 minutes you freeze, then 10 minutes thaw, and then 10 minutes freeze. So this is what we do for when we are doing cryoablation. So we have consoles and we have cryoprobes. So advantage of cryoablation over RFA is that actually you can see the ice ball. So the tumor margin ablation which you are ablating is perfectly, you can millimeter to millimeter you can see it. So you can know that what is the type of tumor, what are the amount of tumor that you have ablated. It's very painless procedure. Cryoablation, we are not giving even conscious sedation, we are doing it under local anesthesia because ice is there, whereas RFA heat is generated, it can be little painful, so that patients we give conscious sedation. Central tumor for which precision is critical, hilar vessels where there are chances that PCS may be injured, so in that patients, cryoablation is favored. Pre-procedure, what we need a recent cross-sectional imaging, either CT or MRI. We need RFTs and ultrasound and CT guidance. Biopsy of renal mass is preferred unless the imaging is very, very characteristic of clear cell RCC. We tend to do biopsies in other cases. So just showing you a few scenarios in which ablation has been done. So this patient underwent partial nephrectomy on right side, and now you see there is a recurrence here in the renal bed. So instead of subjecting the patient to surgery again, so you can, this is a small tumor, you can just put an RFA probe under ultrasound, you can give heat, and then on follow-up you see there is no enhancement and the tumor has been ablated. So another lesion, is not surgically fit, 2.5 centimeter lesion in the left kidney. So here when the patient was kept in prone, so now bowel has started coming in very close proximity to this tumor. So here we can do something which is known as hydrodissection. We put in a needle, we give saline, or we put some dextrose so that we can create a 1 centimeter, 1.5 centimeter space between this and this is, this is the ultrasound image here showing the placement of this cryoprobe. And after placement of cryoprobe, we have given hydrodissection, separated the bowel, and on follow-up, there is no enhancement. Another completely endophytic tumor in left kidney, patient not surgically candidate. So here what we do is we can do cryoablation. So you put one cryoprobe, and if you see the last image, this black thing is during the surgery. So this is actually the ablation margin. It tells you that what is the type of, the amount of margin you have achieved. Complete ablation has been achieved with cryoablation. Larger tumor, cirrhotic patient, CT done for SCC, incidentally detected RCC 4.5 centimeter. So you can place multiple probes. In this patient, we put 3 probes, and you see this black thing around this probe. This is the ice ball. So you, with the ice ball, you can actually make out what is the tumor and the margin which you have achieved. Another last patient, Singh sir must be remembering this patient, High Court judge, very learned man, put on active surveillance, but very conscious that I have a tumor on right kidney, already operated multiple times on left and right RCC some 20 years back, also having stroke. So difficult to switch position, upper pole, medial. This is difficult for us also to ablate, but then we discuss with patient wants to get it removed. So in this patient, we did CT guided RFA probe through transhepatic route. So transhepatic route has also been described, and there are multiple studies now which tells that, because you are, so from segment 6 of the liver we put this probe and we entered this tumor here, upper pole medial, and this was ablated, complete ablation was achieved, and while we are coming back we do track ablation so that there is no tumor seedling. And this on follow-up, you see there is no enhancement, tumor has been taken care of. So outcomes are good for T1A RC, T1B lesions not that good. So choice of ablation method, there is nothing to, actually if you see oncological outcome, one ablation modality is not better than the other, but smaller lesion, exophytic lesion, RFA, central lesion, hilar lesion, endophytic lesion, bigger lesion, cryoablation. That is generally the trend which we follow. So if you see this AUA guidelines, it also tells you that thermal ablation is a valid treatment option in T1A lesions, which surgery is not possible, or if the patient doesn't want surgery. This was our paper on cryoablation. We published it some time back. And with that, I would like to conclude. Thank you for your patient here.
Thank you, Ujjwal. I'd like to just clarify, you mentioned in your first slide, only patients who are not fit for surgery or anesthesia. That patient you are taking for cryoablation, or those who are fit also?
So fit
do
also,
you recommend them also?
Fit also. If a patient wants, and if urologist is supportive, he thinks that no. I mean, in PGI we have got very good supportive urologists, even if patient wants. So they send us, we have done in fit patient also. It's
How
not
many
that.
cases you have done in PGI, and what is the outcome? Do you have any follow-up of your personal?
Sir, total cases would be around 26.
In how many years? 12
Last
years?
3 years, sir.
3
4 years.
4 years.
3, 4 years. 26 patients. So
And how many have recurrence?
2 patients.
2 patients.
Yes.
You have done for kidney transplant earlier.
Yes, sir. 1 transplant patient.
Yeah, in Max, they do it radio frequency quite frequently for initial tumor as well as after the recurrence also. But I have seen more failure and operated them. Even the Wilms tumor, which has recurred, has been treated, then I had to operate. So I have seen more failure. Exact data they have not yet published, but at least I am not very much impressed with the radio frequency. I am more impressed with the cryoablation results.
Yes, cryo has a better result.
Yeah.
Yes, sir. Cryo, actually, we can treat bigger lesion also, central lesion also. And the thing is that you can see the ablation. With RFA, we not exact see the ablation. We assume that probably this is what I have taken care. Whereas in cryoablation, we can exactly see that this margin has been achieved during the procedure itself. So that gives us an extra level of confidence.
I have even treated bleeding after the cryoablation and doing rather emergency partial nephrectomy in emergency setting.
Yeah, thank you, sir, for your comment. Yes, actually, there are so many modalities available for again for tumor ablation, and I am very happy to say that PGI has all those facility. The PGI is the first institute where cryoablation was procured 8 or 10 years ago.
Yes, sir.
And I think then it has been followed by Tata Cancer Hospital. Now we have got RFA, IIREP, irreversible electroporation. Then you have got hyperthermia. Then we have got
microwave and HIFU, sir, also.
Right. So only thing is not available is HIFU.
HIFU is also available, sir.
HIFU is
Available, sir.
Okay, so I am not aware of. So I think we have been sending the patient to them when the patient is not operable, and we could not convince the patient for surgery. Otherwise, yes, surgery remains the mainstay. And then if the patient has got morbidity or something else which prohibits the surgery to be done, then only we send the patient for tumor ablation. Thank you, Dr. Gossi, for coming here and again being with us. Thank you very much.
You also know that one transplant patient had small renal mass.
Yeah.
He was almost about 5-6 years post-transplant. Underwent RFA at PGI Chandigarh. Somehow his creatinine was high at that time. So he ended up into end-stage kidney failure. We did second transplant, and now it is almost 16 years post-transplant. We did not remove the previous kidney, and he is off tumor.
Yeah, actually I asked you to remove that kidney because you tell no, I will not remove, I will do transplant. I don't know, I insisted, please remove that kidney before you are doing kidney transplant, another transplant. Then he removed, there were no tumor available in that. Yeah. That patient developed adenomyomas managed by percutaneous. Again, betadine, again ablation of the betadine.
Thank you, Joel.
Thank you, sir.
Now may I request Dr. Puneet, who is going to speak on the role of partial nephrectomy in small renal masses. Puneet.
Thank you, sir. So, I think both the speakers before me have considered that active surveillance as well as ablation techniques are there as an alternative option for selective patients. Now, we need to give a very clear message here whether what is the treatment of choice. The standard treatment would be partial nephrectomy in these cases. Sorry. So, and why is it so? So, my disclosures are only two. One, I am doing these surgeries, and I'm also a proctor for Intuitive. And as a surgeon, I would definitely like to operate. But by no means that is an evidence for doing partial nephrectomy for these SRMs. So when you choose an option, what are your considerations? The considerations are definitely it's a cancer surgery, so oncological outcomes. Also, the important thing is renal function preservation, risk of CKD development, morbidity of a particular patient, as well as the availability of infrastructure and a skill of physician available. So let us see what the guidelines say. The guidelines undoubtedly says that partial nephrectomy is the preferred option for these SRMs, and the other options are ablative or active surveillance. This is the NCCN guidelines. The EAU guidelines are no different. They offer partial nephrectomy as a standard treatment for T1 tumors less than 4 cm with a strong recommendation. Also, they say that active surveillance and thermal ablation is to be given to frail patients or comorbid patients, and that also is a weak rating because the evidence is not that strong. So, there have been studies which have tried to evaluate ablation techniques with a standard of care, which is partial nephrectomy, but there have been gross limitations in this evidence. The meta-analysis evaluated more than 16,000 patients with 26 non-randomized studies, and this is a chart of 11 meta-analysis, and you see the last column, the overall rating of confidence in evaluating the results in most of the studies was critically low and low at best in two of these studies. So in conclusion, this data suggests that it is inadequate to make any strong and clear conclusions regarding clinical effectiveness of thermal ablations for treating these T1A tumors. Oncological outcomes, if we consider, so when you compare partial nephrectomy with ablative techniques, the oncological outcomes in terms of overall survival in 5 years and more are, and also cancer-specific survival are better in partial nephrectomy as compared to ablation techniques. And it is especially more So in terms of, in cases where the tumor is more than 2 centimeters, so less than 2 centimeter tumor is almost not going to harm anyone, but more than 2 centimeters, 2 to 4 centimeters is the group where actually partial lumpectomy would score more over these ablation techniques. Now, my previous speaker spoke about the case of solitary kidney. You can offer ablation techniques. There have been papers, there has been evidence which have again compared tumors in solitary kidneys, and it has been seen that in laparoscopic partial nephrectomy, the oncological outcomes in terms of survivability and also cancer-specific survival and local recurrence-free survival at 3 years, 5 years, and several years were much better in patients who receive partial nephrectomy as compared to ablation techniques. So now one factor which one would say would be complications of operation. So if you see the data, so overall complications and severe complications were no different in patients who underwent partial nephrectomy versus who, in the patients who were treated with ablation techniques. Whereas local recurrence rates were much lesser, and thus it was in favor of giving partial nephrectomy to the patients as compared to the ablation techniques. So nowadays we do robotic surgery wherever it is available. So with robotic surgery, when you do a partial nephrectomy and compare your data to ablation techniques, the complications, the preservation of GFR and post-treatment estimated GFR are no different whether you are doing a partial nephrectomy or a ablation technique. So there is no advantage of ablation in these patients. Moreover, there are some challenges in interpreting the results of focal therapy. So post radiofrequency ablation, it has been seen in some studies that up to 30% of the patients, there will be, if you follow up with the contrast imaging, which is the method to follow up these patients, there would be a persistence of contrast for 6 to 12 months. However, there would not be any tumor in those. Similarly, in contrast to that, if the patient is having a residual tumor, it may not show up in contrast studies. The contrast may not be there, enhancement may not be there. So you need a biopsy for assessing recurrence in these patients. So when you compare active surveillance to these patients, the cancer-specific survival, overall survival, as well as the cardiovascular specific survival were all better in patients with nephron-sparing surgery as compared to active surveillance. So yes, if you have a frail patient who is elderly, who is not fit for anesthesia, or a patient who refuses surgery, you can offer these ablative or active surveillance techniques. But then for a younger patient who has a good lifespan, you should offer partial nephrectomy as a standard of care, and also in solitary kidney, partial nephrectomy can be offered in these patients. So patients in whom GFR is more than 30 and good life expectancy is there, partial nephrectomy is the choice, and less than 30 or patients who refuse surgery, you can offer ablation in these techniques. So if you have a patient like this, you can actually offer him ablation, and actually instead of ablation, he can be easily observed on active surveillance if the tumor is small enough. So if you have to give anything new, it should be better. It's just not the case that if it is different, you should do it, but it has to be better also. Thank you so much.
Thank you, Puneet. Only one question. The small tumor means 1 centimeter to 4. So what is your cutoff when say ki now these are the ideal cases for partial nephrectomy?
Less than 2 centimeter tumors, if you have, the oncological outcomes are almost similar whether you do partial or ablation, and actually you can do active surveillance for these patients. But more than 2 centimeters, the partial nephrectomy scores more instead of ablation techniques.
More
so
than 2 centimeters.
2 to 4 centimeters is the
No, that message should go to them clearly. Yeah, thank you.
Thank you, sir.
I'd like to make something, comments, things up. So I'd like to thank all the 3 speakers. They have done a good job, and they have clearly mentioned the indications for individual procedures. Thank you.
Yes.
Thank you, Dr. Gopal.
Thank you very much,
Thank
sir.
you,
I would
Gopal.
like to thank all the speakers on behalf of ISU, and I also like to thank our chairpersons. Thank you very much, sir. Now we can move on to the next session, which is basically a case-based discussion. For this session, I would like to invite our panel members. I would first like to invite Dr. Ravi Mohan, Dr. Puneet Aluwalia, Dr. Jatin Sarin, and Dr. Shikha Goyal for this session. Dr. Puneet Aluwalia, sir is there? Yeah. Gopal. So I would first like to introduce our panel members. Dr. Ravi Mohan is Professor, Department of Urology, PGI Chandigarh. Dr. Puneet Aluwalia is Director and HOD, Department of Uro-Oncology, Medanta. Dr. Jatin Sarin is Director, Medical Oncology, IV Hospital, Chandigarh. And Dr. Shikha Goyal is Associate Professor, Department of Radiation Oncology, PGI Chandigarh. So I will just start with the case. This index patient is basically a 66-year-old gentleman with history of LUTS for past 2 years and was found to have elevated PSA, which was 19.1. He is diabetic, hypertensive, sexually not active, IPSS is 9, and on digital rectal examination he has grade 2 prostate with a nodule palpable in both lobes, and he is basically stage 2C. And an MRI prostate was done, which showed prostate size of 19 cc with a Pirates 5 lesion involving both the lobes, from both the peripheral zones from base to the apex, with extraprostatic extension with bilateral seminal-vesical invasion, but no evidence of lymphadenopathy. He underwent a trust-guided biopsy, and which showed adenocarcinoma, Gleason 4+3, all cores were positive and 100% maximum involvement. And subsequently he underwent PSMA PET scan, which showed mild inhomogeneous uptake in the prostate, otherwise no lymphadenopathy or metastasis. So basically he is a clinically locally advanced CA prostate. So I would just first start with radiation oncologist, ma'am. So Dr. Shikha Goyal, I would first ask the question, ma'am, what would be your next step in this patient?
So this patient has been adequately worked up. The treatment option for a locally advanced, at the moment the current standard would be to offer him neoadjuvant ADT followed by radical radiation therapy, and ADT for these situations would continue for at least 18 months. We usually follow it for 2 years. But a discussion has to be made with the patient regarding the duration of therapy, the side effects as well, because he does appear to have BPH also, although the prostate size is smaller. So it should be a comfortable and tolerable therapy for him as well.
So, right, ma'am. So, ma'am, how do you give radiotherapy? Do you give some cycles, do you give some cycles of hormonal therapy before radiation, or you start both of them at the same time?
Actually, for locally advanced, we know that ADT has to continue for it's long-term ADT for these patients. So the advantage that we get out of starting neoadjuvant ADT is that we achieve some shrinkage in the size of the tumor and the size of the prostate. So we are dealing with a smaller volume when we give radiation. So the tolerance to radiation is better because the dose to the prostate is treated in situ when we are giving radiation. So the rectum, bladder, all of those would receive some spillover dose, and those doses can be controlled much better if we are dealing with a smaller prostate size. So that's the advantage that we get. Although for intermediate risk now it is said that concurrent and adjuvant is better than starting neoadjuvant. For high risk, probably the data is not that clear, but we do want to take the advantage of 2 months of neoadjuvant before we go into.
So, ma'am, my last question would be, in your experience, how much percentage of these patients who have locally advanced prostate cancer would finally have biochemical recurrence?
Adequately treated patients.
Yeah, adequately treated.
So for locally advanced, we know that the biochemical recurrences at 5 years would be around 20%.
5 years. Okay.
So that's what in our clinical practice also.
So
we
what
see.
do you do next for these patients?
For a patient who has biochemical
Yes.
recurrence, we would see the PSA and the PSA doubling time. And typically at PSA values of more than 0.5 or so, we should be able to pick up an anatomic lesion also, which would correspond to the site of recurrence. And depending on what that site is, we would plan whether we need to further image or we want to keep on further
Okay.
follow-up or offer
All right.
treatment.
So now I will floor this question next to the two surgeons. First, Dr. Puneet, what would you do in this case?
So I agree with Dr. Shikha that for the patient who has a locally advanced disease, the standard treatment in light of evidence present is radiation with ADT. But the surgery has not been evaluated with randomized study. The study SPCG is going on to compare the two options, and only feasibility has been proven. Long-term data will have to be awaited. But this patient also has LUTS. So we have to also discuss the option of surgery to the patient in light of that and side effects of radiation. And along with that, I think patient should be counseled enough that even if he goes for surgery, the chance of requiring adjuvant treatment would
Yes.
be quite high. Around
So
more
I
than
understand,
50%.
sir. So Ravi sir, do you have any difference in the opinion?
I think I agree with both of them. But such case typically we would go to our MDT where we would have actually Shikha sitting across and Kanan sitting, and we would be discussing the same thing. And
Yes.
it ultimately comes down to that we do a Euroflow as an added modality apart from only LUTS. And if the Euroflow is very poor, then we would err towards surgical choice. Otherwise, mostly they would end up with ADT and RT.
Right, sir. So Jatin sir, would you recommend any neoadjuvant hormonal therapy? I think as Dr. Siddharth had already shown and beautifully elaborated that there are some studies coming up regarding this, giving, I think Eberatron with this has shown survival benefits in phase 2 trials. So do you recommend for these therapies for example, if this patient comes to you?
Well, practically there are no guidelines for it. Practically there are no guidelines, especially before surgery. Yes, for before radiation, we may offer if the radiation oncologist, actually very rightly said by Dr. Ravi, all these things are decided in our multidisciplinary team. So at the present state, practically no.
Yes. Yes, sir. Right, sir. So now next this, so we were able to counsel this patient, or this patient has chosen for radical prostatectomy, and on final histopathology he had upgradation of Gleason score and margins were positive, seminal vesical invasion was there, and 2 lymph nodes were positive. So I would present a few scenarios in front of you, and then I will ask one question. So my first question would be to Dr. Shikha. So ma'am, if this is the scenario, what would be your next step?
Actually, our practice in our MDT is to offer adjuvant therapy to all patients who have 2 or more nodes positive. So in this patient, we would want to offer adjuvant radiation and hormone therapy also. But the thing is that if the patient has to be adequately counseled, and even if we are offering adjuvant therapy, we have to make sure that the continence has recovered maximally before that is offered. So adjuvant therapy, unlike in other scenarios where we offer adjuvant therapy within 2 months or 3 months of surgery, here probably we would wait for longer. The PSA is low, so it is safe to wait longer as well. So we would reevaluate with another PSA after 6 weeks or so.
I understand. So you mean to say that doing salvage radiation therapy is also a good option in such patients who have no biochemical recurrence post surgery, or you will definitely go for radiation therapy?
With node positive, there is no randomized data to guide either practice.
Okay.
Our practice is more towards adjuvant than salvage, but I would not say that salvage is completely out of the question.
So my next question is to Dr. Puneet. Sir, for example, this is the second scenario. If this patient, same patient comes to you, what will you do? Will you refer this patient to radiation, or you will wait for PSA to rise?
So, Gopal, can you go to the histopath slide, the
Yeah.
post-surgical?
Yes, sir.
Yeah. So this patient has a Gleason 4+5, which is quite high, margin positive, SVI positive, and even if like data has told us that for 2 nodes we can even observe, or so, but in those patients the PSA should be less than 0.1. And also the ISUP grade has to be grade 1, 3+3. If you have an ISUP grade 2 to 5 with T3B disease, with margin positivity, and even in the study, which radical study, which evaluated SRT and adjuvant radiation therapy, like one of the speakers presented, Dr. Kannan, I think, presented. So only 20% of the patients had this sort of population with high Gleason grade. So in these patients, it is better to give adjuvant radiation therapy along with ADT.
So my question is, sir, will you? So you have already answered. You say that you will
I will give
you will
adjuvant
refer the
radiation
patient
therapy
for
with
radiation
ADT
therapy.
in these patients. Radiation
Okay.
therapy maybe you can give it 3 months down the line when patient recovers a little bit of
Yes.
continence, but you start on ADT.
So my next question is to Dr. Ravi. Now this is the third scenario, and obviously patient has biochemical recurrence, and there is no doubt that you will refer the patient. So when will you refer the patient for this radiation therapy?
So I think to summarize all the 3 scenarios, scenario 1 we would go for salvage mostly, but as Dr. Shikha said, they are likely to fail since the PSA is low. We'll wait for some time and do adjuvant. But for scenario 2 and 3, the answers are almost clear that they would have to be given for both radiotherapy and ADT, because scenario 3 is a PSA persistence at 1 month.
Yes.
So I would say the moment his continence is regained, we would have to. So till that time, we would start him on ADT and immediately, and then once the continence is achieved well, then we would subject the patient for radiation.
Well, I would differ a bit here. Even if the PSA is undetectable, if it is 0.04 like you showed, if you go by guidelines and the studies which we were discussing, with T3B patient with 4+5 Gleasons, it is better to give adjuvant radiation therapy rather than salvage radiotherapy. Salvage radiation therapy, in light of radicals raves, is to be given to the patients who have IUCP